Madam, we are live.
Okay, Zinat madam and Rehana madam, would you please start, please?
Okay. Assalamu alaikum, ladies and gentlemen, participants from home and abroad. Very good morning to you all. I am Dr. Rehana Parvin, General Secretary, OGSB Tagar branch, welcoming you all to first virtual international scientific conference of endometriosis adenomas Society of Bangladesh. Our session is keynote lecture 2. We are honored to have eminent personality Professor T.A. Chaudhary, Professor Kachidori OTIE as chairperson. Professor T.A. Chaudhary, he is the professor of Obs and Gynecology, former president OGSB, SAPO, BCPS, former vice president, FO. He is the president Fertility and Sterility Society of Bangladesh, recipient of Independence Shadhinata Padam, the highest national award from Bangladesh government. The King of Nepal decorated him Gorkha Dakshit Bahu Medal. Professor Kajinori Uchai, President FO, he is a visiting chairperson, Asian Gynecologic Oncology Group, visiting professor, the Jaiki University School of Medicine, Tokyo, Japan, Executive Advisor, Shin Yurigaoka General Hospital, Kanagawa, Japan, Fellow and Honorary Member, Japan Society of Obstetrics and Gynecology, Honorary Fellow, SCOG, Honorary Fellow, Taiwan Association of Obstetricians and Gynecologists, Honorary Fellow, Korean Society of Gynecology, Oncology. The moderator of the session is Professor Jinat Asre, Professor and Head of Department, J.D. Shikdar Ulmer Medical College, Secretary General, Bangladesh Mariposa Society, Scientific Secretary, OGSB. Now over to moderator.
Thank you, Dr. Rehana Parvin. Thank you very much. It's my proud privilege to be the moderator of this session. Assalamu alaikum and good morning. And we are very honored to have two very eminent speakers with us today. And I would just give a gentle reminder to the speaker that you have 20 minutes for each presentation. And as it is a keynote speaker session, we don't have any question answer, but definitely we get all the answers from the keynote presentation. So first of all, I'd like to call upon Professor Samina Chaudhary. Professor Samina Chaudhary, would you please give the CV of her? Professor Samina Chaudhary, madam, she is actually the dynamic president of Endometriosis Adenomyosis Society of Bangladesh. She is the immediate past president of OGSB. She is the chairman, OGSB Hospital and IRCH. She is the chairman, Endometriosis Subcommittee of FIGO, and she is a member of FIGO, the Committee of Human Rights and Refugee and Violence Against Women. Welcome, Professor Samina Chaudhary, for your presentation. And her presentation is a school-based intervention for creating awareness on endometriosis during the COVID-19 pandemic in Bangladesh. Welcome, Professor Samina Chaudhary.
Okay, thank you very much. I am sharing my screen. Is it visible?
Yes, yeah, it is visible and also audible.
Okay. Thank you, Dr. Jinat. First of all, I want to welcome our chairperson and the participants. I must show my respect to our teacher, Professor T.A. Chaudhary, who is the chairperson of this session, and also Professor Kajunuri OTI. and all the participants. Welcome to the presentation on school-based awareness program on early detection of endometriosis. And I have nothing to declare. You all know that endometriosis is an estrogen-dependent chronic inflammatory condition associated with severe life-impacting pain during menstruation, sexual intercourse, defecation, urination, and sometimes anxiety, depression, and infertility. 10% of women and girls are the sufferers globally. Approximately 1.2 million Bangladeshi women are sufferers of this endometriosis. And you all know that 1 in 10 and also 40% are sufferers of infertility. And throughout the world, 176 million are affected with endometriosis. And there is almost no cure, but still we can reduce the sufferings. And also there is a diagnostic delay is the problem. You can see this slide and already you have seen it yesterday, and the widening impact of endometriosis, the individual impact and the societal impact. You can see that the diagnostic delay is usually 7.5 years to 10 years. And by this time there is 3 to 4 doctors are changed. And what is the implication on the economy? It has been found that not only the sufferings of individual, but there is huge medical cost, surgical cost, and caregiver cost, absenteeism, and reduced productivity at work. And it has been found that it's a big burden, and $1 billion are spent in this field. And this slide, it's also a very popular slide. Many of these, our presenters are using these. The activities negatively impact by symptoms in 8 countries. This report showed that sexual life is hampered in 50% of cases, and relationship of the family is disrupted in 36% of cases. Performance at work and school and university, 35%, and also housekeeping problem with the 34% of cases, and attendance of university and schools, 32% of cases. With this background, we have conducted one study on school-based endometriosis awareness and screening program in Bangladesh during the COVID pandemic in November 2020. This study is ongoing with the objective of creating awareness and reducing delay in the diagnosis of endometriosis. So far, data has been collected from both online and offline survey questionnaire in 48 adult girls at 5 different schools. Analyzing data by using the algorithm through apps to detect the high-risk group of endometriosis. The high-risk cases are being evaluated by gynecologists through clinical examination and ultrasonography. You can see the data was collected in the school and also online collection of the data through the apps. But it was not easy to go through this process. Before that, we had to work on it. As first of all, we have to sensitize school authorities and the teachers. At first, awareness on endometriosis orientation of the app and the data collection process was provided to the teachers. Consent and approval was taken from the school authorities and parents, and data collection plan has been devised by maintaining the confidentiality. During the process of this collection process, we have faced many girls and women who said that Miss AS, she is only 14 years girl with, she is reading in class 8. She told that my first period started at 12 years of age. For the last 9 months, I have severe abdominal and back pain during period. It hampers my regular study. I have missed 3 class tests in the last week for this excruciating pain. Painkiller doesn't work. Frequently, I miss family programs for any festival or reunion. Now I am getting frustrated day by day, and I am becoming more introverted. I sometimes ask myself, when will this pain end? And she asked one question to us, can you give me a pain-free life? Next. This case of 25 years woman, married woman of married for 2 years, she is a school teacher. She told that I have started my period at the age of nearing age of 12 years, and since then I have agonizing abdominal pain during each menstrual cycle. I am a school teacher and married woman. At my workplace, I cannot concentrate on my work properly. Often I have to leave classes and staff meetings. On the other hand, I sometimes fail to contribute to household activities. Difficult to maintain a proper relationship with my husband, thus causing a marital disharmony. I don't know how long I have to go with it. Both of us are depressed and frustrated. How I will be a mother? I'm now worried about my students also. I try to communicate with my students who are facing similar problems because I know nobody listens to me. Nobody understands my pain and suffering. This is a housewife. She is 45 years and the mother of a girl. She also told that she had started her menarche, and after that she felt pain during menstruation. And at the age of 30, I became a mother of a girl. After my first childbirth, as I started again experiencing severe lower abdominal pain and irregular menstrual period. I wanted to conceive another baby since the last 15 years. I consulted with a couple of gynecologists and diagnosed as endometriosis and infertility. And I am depressed and not having a normal family life. I am now concerned about my daughter's condition because she is having the similar type of symptoms and maybe going to compromise her quality of life. I am very much worried. These are the stories, and you all know, you are accustomed with this. In this methodology, what we have done, identify the impact of endometriosis among the adolescent girls virtually and on-site, and obtain consent and option to withdraw, and maintain confidentiality, secure participants' information, and interact via text messages and phone, and clinical examination, ultrasound, suspected cases, and advice. You can see the pain scale. The VAS score was used to monitor the pain problem, and we have a consent form, but we have converted in Bangla also in our local language. And the app in our study group, we have got one software architect, and he helped us to make this app. And in this app, there is first of all, they enter into the home screen, then there is a communication screen, and then the Microsoft Azure DevOps, and also Google Firebase and database. And in this app, we have used this algorithm with questions, and whether she has got menstrual pain, and what is the intensity, and what is the characteristic of pain, and what happened. Ultimately, we try to find out the high risk and the low risk group. And you can see this survey result, that the first question, do you have any pain during menstruation? 54% says yes, and occasional is 31.9%. And about the pain intensity, the VAS score scale above 4 and below 4, almost similar, 50-50, said their pain score is like that. And about the pain characteristics, it has been found that which matches to our high risk group, that before the onset of menstruation intensify in the middle and continues at the end, it said about 5.7% cases. And about the quality of life, we have asked few questions. And, regular day-to-day work, 16.50% said that they have got problem with that. And another said that they have their hampered study, regulatory work, and also the quality of life, 7.30% cases. About the family history, we also asked whether mother and sister together 0.9%, and also about only sister 6.60%, and also about mother suffering is also 6%. Ultimately, it has been found that the algorithm said that the high risk group is at the time of survey was 6.3%. This is the dashboard, and you can see that the age of menarche is 11.9 years, and you can see the current results. And of which 14 to 17 years girls are the major group, and is about 56.5%. And about the family history, already I have mentioned it in the earlier result. And evaluation of high risk cases detected from the Adlendo app, and they are seen by checked by registered gynecologist, and all of them had ultrasound free of cost. Now we can see that importance of school-based program in enhancing endometriosis cases. You can see a systematic review recommends that strategies to lessen diagnostic delay of endometriosis in adolescents must include integrated action by educators and healthcare providers to improve health literacy and awareness of common causes of pelvic pain in this age group. Another study you have said already, you have seen yesterday by Deborah Bush. She presented paper, Endometriosis Education in School, a New Zealand model examining the impact of education program in school and early recognition and symptoms suggesting endometriosis. The study suggests strong evidence that consistent delivery of a menstrual health education program in school increases adolescent student awareness of endometriosis. This study also puts strong evidence that health-seeking behavior of adolescent women increases in geographical area with consistent delivery of menstrual health education in schools. Another model in Canada's first school-based lesson on endometriosis. A 60-minute lesson on endometriosis has been included in school education program at Vancouver, and is being taught to students of class 8 to 12. And Maureen Stranger said that our students are learning more about health issues, early detection, and health promotion. Now, in the conclusion, what I can say that the intervention has the potential to be easily administered, culturally acceptable, feasible, and quick process to detect endometriosis cases among the adolescent schoolgirls in Bangladesh. Sensitization of the healthcare practitioners, adolescent professionals, and broader community about the endometriosis and public health education initiative should be taken. Increasing the availability of technology with algorithm to help the health system achieve early recognition and diagnosis and management of early endometriosis. Promotion of health policies that ensure endometriosis sufferers have access to at least minimal level of treatment and support. In circumstances where the gynecologist or the advanced interdisciplinary experts are not available, primary healthcare should screen, detect, and treat endometriosis sufferers. And in our research team, I acknowledge them, and this is a research group and also health informatics team. I want to show acknowledge to them. And this is the last one. Thank you very much for giving me the session sharing. Thank you all.
Thank you, madam. Thank you very much, madam, to share your studies with us. Really congratulate you for your hard work, and probably we will know the result at the end of your study. We have all the best wishes for your study, madam. Thank you very much. So now I'd like to call upon Professor, our second keynote speaker, Professor Sun Wei Kyu. Professor Sun Wei Kyu, He is the professor of Shanghai Obstetric and Gynecological Hospital, Fudan University. He is the board member, Asian Society of Endometriosis and Adenomyosis. He is the first president of ASEA, and he's also the board member of World Society of Endometriosis, and he is the board member of Society of Endometriosis and Uterine Disorder as well. Let us welcome Professor San Wei Kyo. Would you please unmute yourself? Professor San, yeah.
Salam alaikum and konnichiwa and good morning and good afternoon where you are. First, I'd like to thank the organizing committee for having me. I will have to congratulate. It is a wonderful meeting, and I told my Chinese colleagues that how wonderful job your Bangladesh people are doing. Thank you. So today, what I'm going to do is to talk about cancer driver mutations and malignant transformation in endometriosis. Now, I have nothing to declare. Now, we do know that there are some cellular behaviors that endometriosis resembles to the cancer. For example, invasiveness, recurrence, angiogenesis. And we also know that there's that ovarian cancer connection. In fact, it was first reported by Samson, but the overall incidence is not very high. It's about 0.7 to 1%. And also connect with the other malignancy, but mostly involves ovary in 75%, and 25% of induced malignancy involves extra ovarian tissues. And in most common areas, it's actually rectal, vaginal septum, colon, vagina, but rarely seen in intestines, bladder, or urethra. So the interest in the malignancy issue is actually rekindled by this paper published almost 10 years ago. It's essentially reported the risk of developing ovarian cancer is increased, but actually if you examine all the published papers, it's actually the increase in relative risk or the incidence, relative incidence, standard incidence ratio is actually not very high. It's about 1.6, 1.4. And the interest in malignancy is actually also rekindled 8 years ago, actually, that was published. There's a paper saying there's a genome-wide sequencing. They actually detected some cancer driver mutations. And especially for the New England Journal of Medicine, this paper, and also there are several papers coming out essentially documenting the cancer driver mutation or cancer-associated mutations. And actually these cancer-associated mutations is actually a euphemism. It's referring to cancer driver mutations as opposed to passenger mutations, which is non-essential mutations and does not have any selective advantage. And this is actually a very wonderful job that is done by a Japanese research team. They actually documented mutations not only in ectopic endometrium, but also in utopic endometrium as well. And not only in endometriosis, but also they found that in adenomyosis, there's also cancer driver mutations as well. So when we think about it, the somatic mutations in cancer has a very long history. And we do know that they're intimately related. There's oncogene, tumor suppressor genes, and also they will have a chromosomal aneuploidy, loss of heterozygosity, genomic alterations, copy number variations, and microsatellite instability. We can use different tools to detect this. And there's also germline mutations in cancer, and for example, the BRCA1 and breast cancer and ovarian cancer. Now, the question is, do lesions come from these mutation carrying endometrium? And this is actually a big issue. And would CAMs in endometriotic lesion confer increase the risk of cancer or malignancy? And how often do these mutations occur? What kind of clinical implications, if any, do these mutations have? And also, when a patient with endometriosis is found to have the mutation, should she be concerned or worried? Now, to answer these questions, we first have to understand that how these kind of mutations are actually discovered or reported fairly recently. In fact, that the search for somatic mutations in endometriosis dates back in 1990s. And we had this paper that published almost, 15 years ago that reported genomic alterations in ectopic and utopic endometrium. And also, these kind of research didn't pan out simply because there's conflicting results, not much mutations, and very few. And also in terms of functional significance, it's not very clear. But also it's hampered by the technological constraints because a detection position is poor, and they also did not use the microdissection. But with the use of microdissection and also next generation sequencing, that improved our capability of detecting the mutations. And this is actually what the microdissection means. And this is actually sections. You can use the laser to essentially cut off these glandular epithelium and also whatever you actually want. You can precisely harvest the cell type that you want. And we do know that the we all have genomes, and the genome actually composed of 3.1 to the billion base pair, and the mutation rate is very, very low. Still, that our human beings are composed to the power of 13 to 14 cells, and we all started from a fertilized egg and come to being through successive mitosis and cell divisions. And each cell division is just like a Xerox process. So the chance of no mutation occurred in all these cells is essentially new, in the sense that if you toss a fair coin consecutively 45 times and getting all the head all the time, I think that's the chance of getting no mutations. In other words, mutations is bound to occur. Now, as the detection rate error actually decreases, more mutations in more people are actually discovered. So that's the era that in the 1990s, and actually, or 1990s is the essentially the mutations we actually did only find very little is actually only in the cancers, but not in the healthy tissues. So in 2015, there's a high-profile paper looked at the normal human skin as actually eyelid. They actually procured eyelids and did a next generation sequencing, and they actually found a lot of cancer-driven mutations. So the message is, yes, cancer-driven mutations can and do occur in healthy, apparently healthy tissues. And then 3 years after, there's also, they looked at the normal esophagus tissues, and they actually found that these mutations actually increases with age. This picture is very clear that this actually these are all mutations, and these as the cycles actually the size of the clone. And you can see for a younger person, not much mutations, but for the 50 years old, there are more mutations, and these clones with carrying the mutation are larger. And for 70 years old, actually, almost all of the tissues actually have mutations. And also for the endometrium, normal endometrium, essentially the same thing. The mutation rate actually increases with age. And there's another paper that's just published last year. They actually looked at the normal endometrium epithelium. And essentially, they found all the cancer mutations you can think of. And essentially, that is it all increases with the age. And they also found that essentially almost 90% of 28 women had potential mutations. The youngest one actually had a KRAS mutations in her endometrium. And 60% of the endometrial glands carry at least one cancer driver mutations. So not only the age, but also the risk factors or lifestyle also that will increase or decrease the mutation rate. In this case, we know that the smoking will actually increase the mutation rate. And in this, and also alcohol consumption also. And for endometrium, whether it's going through the pregnancy, using of the contraceptive, that will also affect the mutation rate. So in the short, mutations can occur in seemingly normal tissues, and the amount of the mutations is proportional to increasing age, which is essentially the replicative error, and also cell turnover rate. If the cell actually has a high turnover rate, then it has more mutations. And also the amount of exposure to deleterious stressors, for example, UV light, smoking, drinking, that sort of things, is inversely related with parity for endometrium. So the question is, do endometriotic lesions come from mutation carrying endometrium? That's actually very difficult to establish simply because endometrium is actually multiclonal. And there's actually this toward work that we actually found that this is actually the Japanese group that they demonstrated endometrium is actually monoclonal in a sense that they have different clones. But on the other hand, for a particular endometriotic lesion, that's monoclonal. So in order to see that this particular lesion is come from one particular clone from normal endometrium, it's actually very difficult to establish. Now we know that there's a human evolution that from essentially from a lower organism to evolve to human beings, and we also know that all the common we all have a common ancestor. That's the out of Africa theory, because all modern humans descended from a common female ancestors in Africa. Now the question is, how actually did they do it? How did they actually come into this kind of a conclusion? In fact, that it's actually very easy to do in the sense that what they do is comparing the protein sequences or DNA sequences. And this is actually for example, different populations and the different protein variations that essentially construct genealogy trees. And they can see, oh, yes, we can actually trace back to the common ancestor, and that's the EVA. And same thing, that you can actually think of each cell as each individual, and you can do the same thing. Different clones, you can actually construct the genealogy tree by measuring the number of mutations and which mutations. So in this case, there's actually so far there's no data to show that there's a genealogical trees that are connecting the ectopic endometrium and eutopic endometrium. So we still cannot see. In fact, this is actually a paper that published 2 years ago. And you can see this is actually the paired ectopic endometrium that carries some cancer driver mutations. And this is actually paired eutopic endometrium. In fact, that you can see that these are 5 patients. And this is a normal eutopic endometrium. And you can see that some of the mutation, they don't carry the same mutations. It's possible that the clones they use, they sampled in ectopic endometrium is not the original one that actually developed into a ectopic lesion. So the evidence is still not there yet. And the other question is, would mutations in lesions will confer increased risk of cancer? The short answer is not necessarily. And simply because, first of all, we do know that all healthy tissues carry mutations. And cancer is actually formed when the right type and the right number of mutations are acquired and accumulated. And actually, this will take time. And most lesions carrying mutations will be removed because of the patient complaint of pain. She will seek medical attention. So by the time that before the lesion they become fully malignant and cause symptoms, she may already have the sought medical attention and had her lesions removed. So, and also that may require multiple hits and probably will need some additional epigenetic operations. And also medication can keep the lesions in dormancy. Now, the other question is, how often do mutations occur? Aging is one. Menstruation essentially is the tissue repair and tissue injury and repair. And also the hypoestrogenism, it's essentially a fuel to speed up the growth or division. So in this case, it's actually they will speed up the mutations and increase inflammation or oxidative stress that also will increase the mutation rate. That will also reduce the repair efficiency, but cell division rate actually will decrease as one ages. That's actually reported 2 years ago. So in this case, that the answer is that the overall, the incidence of ovarian cancer due to ovarian endometrioma is actually very low. And that's actually explained. Now, we do know, at least we have it's kind of a grip, although we'll still have to work out some of the details. In the endometriotic lesion is because of the cyclic bleeding. It's just like a wounds, experiencing cyclic repair, injury, and then repair. And some of the molecular processes are ongoing that eventually lead to the culminated with the fibrosis. At the same time, it will accumulate mutations and also will cause cancer mutations. And there are several factors that will speed up the mutation, but also there's some mitigating factors that prevent or reduce the mutation rate. So in this case, we have to ask ourselves, what kind of clinical implications do these mutations have? Now, from once there's a mutation, it is very difficult, probably impossible to rectify these mutations because these mutations are simply the DNA aberrations. And there's no drug that can actually rectify or reverse the mutations. But one paper that carried out in adenomouse found that for those carrying the KRAS mutations, their response to progestin is actually substantially reduced. So in this sense, once there's carries mutations, the treatment will be much more difficult, simply because drugs cannot, especially hormonal drugs, cannot rectify the mutation, and also their response to hormonal treatment will be reduced simply because of the progestin receptor expression is actually reduced. So now, when a patient with endometriosis is found to have a mutation, should be worried or concerned? My answer is not necessarily. As long as lesions are removed, the risk of malignant transformation is actually extremely low. And if she used the hormonal treatment, that it will essentially, for example, causes the amenorrhea. So the lesions actually still will be in a atrophy or dormancy. In this case, there's no more or reduced cell divisions. So in this case, actually, the cancer risk is actually low. Of course, you can still use see a patient with the, but there's usually once you see the patient's actually normally younger than if she doesn't have the endometriosis. So in conclusion, cancer driver mutations are ubiquitous, even in healthy tissues. And endometrium, 60% of endometrial glands carry at least one mutations, but the prevalence of endometriosis is nearly 10%. And the incidence of endometriosis-associated ovarian cancer is actually low. And research in cancer mutations in endometriosis shed some new light into the pathophysiology. And we do know that they occur in endometriosis simply because of the replication errors and selective pressure, thanks to increased estrogen levels, inflammation, iron overloads, and oxidative stress. And their presence poses a therapeutic challenge. So early intervention is always advisable in order to stop the cell division and remove these stimulants. And so there's no need to panic. And also there's actually the papers on cancer-associated mutations in endometriosis. And also, I think that the take-home message that I actually wrote in 6 years ago still stands. The increase in malignancy is actually relative increase is moderate, but the absolute risk is still low. Incidence low, so there's no screen test can ensure a high accuracy. Even you had anyone, because the incidence is low, you're likely to get false positive. So it's sounding a false alarm. So screen is not necessary and probably not useful. So in this case, we have to be aware of this. So thank you.
Thank you very much, Professor San Uikyo, for your brilliant presentation. I mean, it's really very new for us. You have nicely described the predisposing factors for, cancer driver, but still we are in gray zone. We don't know how to precisely predict that this patient will go to have malignancy or not. But one good thing you said, that the risk is very, very absolutely low. Thank you very much. Now it's time to go to our chairpersons of the session today. I'd like to request Professor Kajirul Shai for his valuable comment on this webinar. Professor Kajirul Shai, please.
Hello, can you hear me?
Yeah.
Yeah, I can hear you.
Okay, thank you. I have to congratulate the first virtual endometriosis Congress in Bangladesh. It is very important issue that endometriosis is not the disease of the woman who has the menstruation, but it is a kind of lifetime treating disease from puberty to postmenopause. And thank you for the nice presentation, Dr. Chowdhury, and also Dr. Kuo. And it is, you showed a very important point of the endometriosis, especially that I'm the oncologist. So I'm very interested about the malignant transformation of endometriosis. Thank you for summarizing the updated the information for all the participants. Thank you very much.
You're welcome.
And can I ask some questions about the malignant transformation, Professor?
Yes,
Kuo?
sir. Yes,
Please.
sir, definitely.
Yeah, please.
Okay. Because of your take-home message shows that don't panic. That's true. That's very important.
Yeah.
And the recently that endometriosis, those who have endometriosis or the endometrial ovarian cyst are increasing. And when I was in the training period, my mentor, who went to the United States, and he wrote to me at that time. The letter is the normal way of the correspondence. But he wrote me a letter that he was so surprised to see so many endometriosis patients in young around the puberty, and that's the kind of case report case report of Japan at that time. But now it's different. That endometriosis is a kind of very common disease, and why it so changes the how do you think, Dr. Kuo, that the incidence of the endometriosis itself increases around the world? Why does it happen?
Thank you. This is an excellent question. And I think that so far there's not much studies, but personally I can think of several reasons. For one, I think that in terms of fertility, especially in Japan, actually it's been dropped substantially. I think that after Korea, Japan also has a very low fertility rate, right? I mean, I think that in Korea they're talking about, worry about 20 years after, there's probably no, usually the replacing rate is 2.2, but in Korea right now we're talking about 1.2. In Japan, it's probably 1.6, 1.8 in terms of fertility, right? So this, because of a reduced pregnancy and also delivery, that actually increase the risk of developing endometriosis. And that's for one thing. Mm-hmm. And second is lifestyle changes. For example, the stress. We have actually shown that the stress can accelerate the development of endometriosis. If you think of the Sampson's theory is true, so essentially there's a retrograde menstruation. So initially there's a very tiny lesions, but if you have a very healthy immune system, some of the lesions, tiny lesion, I mean, actually that the Konsan actually did some very nice work for the occult endometriotic lesion. These occult lesions could be eliminated by the healthy immune function. But if the woman is stressed, is depressed, and that will actually activate the HPA axis, and they will generate lots of cortisols and also adrenalines that will in turn activate the adrenal receptor on these lesions. And that will also speed up the progression of these lesions. So you will also see the more cases. The third one is probably people are now, they go to sleep very late, that the night shift, and also that will also increase the risk. And also the diet. There's some data to show that the high-fat diet actually will increase the risk of developing endometriosis. And I think that the Japan traditionally is a low-fat, very healthy diet, but because of the change in lifestyle, more young people actually adopting Western-style diet. And I think that the beef consumption is probably not much before 20 years ago. But now beef consumption, Wagyu have Wagyu, and it's actually these high-fat red meat will probably also increase the risk of developing endometriosis. So everything put together, you'll probably see increased risk, increased incidence of endometriosis.
Okay, thank you very much.
Okay,
thank you very much. Yes.
May I ask some question?
Sure. Okay, one question probably. Then we shall go to our professor.
Okay, so I have a short questions to the Sangwei, Professor Sangwei. Okay, Sangwei, thank you so much for a very, very elegant talk. I think all the doctors of the OBGYN doctors in Bangladesh, they could take some very good essence from the content of your talk. It is very, very fascinating and exciting topic. So my question is, coinciding with the previous talk by the Professor Samina, and also the epidemiological study which we are doing now, do you think that this kind of questionnaire survey or the school-based program for the early detection and management of endometriosis, it may protect or slow down the cascade of progression to the advanced stage, and also the cascade of progression of the fibrosis? Do you think we take this step for these younger ladies or the adolescent ladies? Do you think we can also protect the cancer-driven mutation process and also the malignant transformation?
Excellent question, Constant. I think that your point is a very important one. I think that's yes, I think that so far there's a lack of awareness. Well, even in developed countries, I think that I can give you an example. Now, in 2018, the Google published a list of 10 most searched questions related to health. One of them is, what is endometriosis? That's because there's one American actress, I forgot her name, it's a link, whatever. The actress actually had endometriosis, and she actually had her uterus removed, presumably very severe. And 8 months after, she had another surgery, and she had a bilateral oophorectomy. Simply because I think that the symptoms are too severe to control by medication. And she actually blogged it so everybody knows. And they actually searched the website and to see what is endometriosis. So even in developed countries, the awareness of endometriosis is not high. In fact, last year, in UK, the United Kingdom, they actually published a report. I think the all-party parliament group or whatever, it's a 60 pages report. And then they actually distilled 4 suggestions. One of the suggestions is to increase the awareness of endometriosis. Now, this kind of education program you're talking about will surely raise the awareness of endometriosis and also offers the education. In fact, Deborah Bush yesterday talked about me education, and I think that's very, very useful. In the case that they educate these adolescent girls, young women to be aware of, this pain is actually not normal, have to be taken very seriously. And we do have the means to do ultrasound, not necessarily transvaginal. You can actually do the like abdominal or very simple, non-invasive, nothing. But still, it's very difficult. In fact, in Shanghai, we conducted an epidemiological study on middle school and high school kids. And we are very surprised to find that up to 70% of these young girls, they actually reported some degree of dysmenorrhea. But when we offer the option, we can actually bring ultrasound doctor, they can get a free examination. We're not talking about transvaginal. Only like maybe one or two in 100 girls, they came over to say, okay, give me the ultrasound. It's very, very difficult. Now, without ultrasound imaging, it's very difficult to see whether this person has the ovarian endometrioma or not. So I think that yes, we do have a publication saying that yes, in younger women, the extent of lesional fibrosis is much lower than the adult forms. So in a sense, these younger women, once they have the endometriosis, on average, they have the lesions that are less fibrotic, and also they have higher the expression of progesterone receptor. They should respond well to hormonal treatment. So in other words, if we institute an education program, identify these patients early, and they're likely to respond very well to hormonal treatment. So they can disease controlled. They can actually, once you have hormonal treatment, the lesion actually will not grow anymore. So in this case, you can actually reduce the risk of having cancer-driven mutations.
Thank
you so much.
Yeah.
Thank you, Professor Khalid Khan, Professor Kajina Rusha, and Professor Khalid for very interactive, informative discussion. Anyway, we have seen lots of factors to drive mutation, but still we love to know which gene is important so that we can go for the genetic engineering.
Right.
Thank you very much. So with this, I would like to go to Professor T.H. Chaudhary, sir. Sir, would you please comment on this webinar? Professor, welcome. Welcome to Professor T.H. Chaudhary, sir.
Thank you very much. First of all, I would like to thank the organizers for inviting me to join this webinar. As a matter of fact, I think this first presentation and the second presentation, both are somewhat related. As it has come out from the discussion that early diagnosis of endometriosis is important.
Yes.
This is for two reasons. One, to prevent the long suffering, generally said 8 to 10 years before the endometriosis is actually diagnosed. And during this time, the young girl goes on suffering. She gets lots of difficulties with her schooling, her social life, and if married, with her sexual life also. Second important thing is that if you can diagnose endometriosis early, there are two benefits. One is you can give the patient relief from symptoms, and these are sometimes quite debilitating, as we have heard. But the second and more important is that if you can catch these lesions early during their genesis, during their origin, and if you give proper treatment, it is not only possible to suppress the lesion and prevent their further progress. So that nowadays we get endometriosis quite late when the disease is quite advanced. But if we suppressed it in the early days of the girl's life, possibly many of these cases would have been diagnosed at a very early stage and possibly will require less radical treatment in most of the cases. So if you want to catch these young adolescent girls, in many countries there are different mechanisms, but in a developing country like ours or our neighboring countries, school is one of the best approaches to reach these girls. But the problem is, even the teachers in many schools are not really convinced because they have got no knowledge about endometriosis and they think it is a natural course that girls will go on suffering for a few years after the onset of menstruation. So this is natural. And I think Samina will agree with me that it had been difficult even to convince some of the teachers just to allow their girls to join in these discussion meetings. So it is not always easy. You have to change the mindset of the people. But the value of early diagnosis and early detection and appropriate treatment cannot be overemphasized. It is always there, and I think it is time that we should go for this. Many cases will not require even invasive tests. You will be able to detect it on the basis of clinical examination and the patient's symptomatology. And if you go on suppressing, because we have got one advantage, that this is a estrogen dependence lesion, and you can counteract the effect to a large extent by giving appropriate progestational agent. So that is the most important. And the mainstay has been, we are using different progesterone, and as time goes on, we have come up to the level of oral GnRH analogs, which are actually suppressing the estrogen secretion. So development will occur, possibly will move more from surgery to medical treatment. And as has been said, that though there is a small risk is not very high, but malignant transformation is a possibility. Of the epithelial ovarian tumors, if you consider only the endometrioid tumors or clear cell tumors, there will be a background of endometriosis in many cases. So even if we do not think that these patients, once they get relief of symptom, we will just forget about it. We must keep them under surveillance. Screening may not be cost effective, but surveillance definitely is. So important thing that transpires from this webinar is endometriosis can and should be detected early, should be treated early, and so that the patient do not suffer from debilitating side effects, and also the condition does not progress further, and in many cases will actually regress and may disappear altogether. So with that optimistic note, I think this webinar has been very useful. So thank to the speakers for bringing this into focus. Thank you very much.
Thank you. Thank you very much, sir. Thank you very much, sir, for your very valuable and very focused opinion. Thank you, sir. And really, we are all optimists. Now, I'd like to request Dr. Rehana Parveen to have her formal vote of thanks.
Thank you, madam. It is my pleasure to thank the honorable chairpersons. My thanks to the speaker, their excellent deliberation, which has enriched our knowledge enormously. Thanks to moderator. My hearty thanks to participants for being with us. Now, over to next session to Dr. Fauzia Akhtar. Thank you.
Thank you. Thank you. Thank you to all.
Assalamualaikum. Ladies and gentlemen, participants from home or abroad, good day to you all. I am Dr. Fauzia Akhtar. Welcome you all to first virtual international scientific conference of Endometriosis Adenomyosis Society of Bangladesh. Now it is the time for plenary session 4. In this session, we have two chairpersons. We are honored to have Professor Farooq Jaman, past President, Society of Obstetricians and Gynecologists, Pakistan, and past President SAFO, and member Executive Board, International Federation of Gynecology and Obstetrics, and Dr. Fessy Luis, Associate Professor, Department of Reproductive Medicine and Surgery, Amrita Institute of Medical Science, Kochi, and Vice President Foxy, as a chairperson. The moderator of the session is Professor Begum Nasrin, Chairman, Department of Obs and Gynae, BSMMU, and Publication Secretary, EASB. Now, over to the moderator, Professor Begum Nasrin.
Thank you, Dr. Fauzia. Am I audible?
Yes, yes, madam.
welcoming you all to this session. Dear audience, in this session, we have two eminent speakers. Each speaker will get 20-minute time for his presentation. The speakers are humbly requested to complete their presentation in time. If the participant have any question, please give it in the chat box, which will be discussed at the end of the session if time permits. Now, it is the time. It is my pleasure to introduce the first speaker, Professor Firdausi Begum. She is the president of Obstetrical and Gynecological Society of Bangladesh, past president SAFO, and Focal Point Bangladesh, FIGO Initiative for Prevention of Unsafe Abortion, PPH Pandel Project. She will talk on endometriosis and everlasting challenges. Please welcome Professor Firdausi Begum. Madam. Firdausi Madam. Sharmin Madam ke ki dekha jaye?
Ji, Madam with us.
Assalamu alaikum and a very good morning to you all. Good morning and good day, of course. Thank you for the kind introduction and the respected chairperson, Professor Farooq Zaman sir, and very dear Dr. Faisal Lewis, and all our senior teachers, my dear colleagues from all over the world, and of course my co-session presenter, Dr. Dash Mohapatra, our brother from the neighboring country. The topic which I like to discuss is the challenges regarding endometriosis. Let me share the screen. Nasrin, is it visible?
Yes, madam.
Okay, thank you so much. Okay, so the topic is the endometriosis and everlasting challenges. And from this conference and our previous experiences, this is very justified topic, which I understood that there are challenges all over. And from the very beginning, and as the disease is progressing, the science is progressing, and we are knowing about the progress and the recent updates, we are much more sort of confused, and not only confused, are facing different challenges. So regarding definition, I'll not go much, but if we look at this definition, that endometriosis is an inflammatory condition characterized by lesions of endometrial-like tissue outside the uterus and is associated with pelvic pain and infertility. So I think the big controversy will be starting from here, the challenge from here, that how do we define? Because there are so many definitions as the etiologies are sort of explored and coming out. So the definition, the etiology is changing, and these are challenges. The issue which has just been talked over by Professor T.H. Chaudhary sir, that the delay in diagnosis. From the patient's perspective, the delay in getting the diagnosis is of major concern. And also from our perspective as well, the time from the appearance of the symptom to a definite diagnosis is from 5 years to more than 12 years sometimes. Even with increasing awareness of endometriosis, the diagnostic delay has not been shown to be shortened. For different reasons, we know this. The mean delay in diagnosis was 6.7 plus or minus 6.2 years, and the median delay is about 5 years, which has been shown in the study. Just I'm going to highlight some slides. Women reporting infertility in addition to pain did not have a significantly shorter delay. So it's when there is only one complaint of pain, but if it is added with infertility, that also does not reduce the time of diagnosis. The main delay in diagnosis in women being diagnosed in the period from the study that has been done here and from updates. So this has been shown that with the years of our experience with the newer advent of treatment and diagnostic modality, the delay in diagnosis didn't improve much. There are exceptions, of course, but this is the general delay. The median interval of the first onset of symptom to diagnosis is sometimes 10.4 years. This is another study. 74% of the study received at least one false diagnosis. Factors significantly prolong the diagnostic delay are misdiagnosis, mothers considering the menstruation as a negative event, and normalization of dysmenorrhea by the patients. So these are the issues we need to think about, talk to the patient, and consider when the patient comes with the apparent diagnosis of endometriosis. So the delay can be from the patient side, the patient delay. The parents of the young girl may consider painful menstruation to be a normal pattern or misinterpret the symptoms as a refusal to go to the school. The consequences may be reduced school performance, social isolation, and a poor self-esteem in a vulnerable period of women's life. It is important to inform young women about the menstrual symptoms which should be considered abnormal, such as cramps, not responding to either painkillers or NSAIDs or cyclic oral contraceptives. So these are important. In addition to, in endometriosis, there are often two-edged swords. So if we go for earlier diagnosis, taking care too much, that may be often a problem. Similarly, the delay is often a problem. So we need to balance properly. There may be a doctor's delay. The consultation with general practitioner or a pediatrician is important, but are they prepared to understand and interpret the symptoms? Are they aware of endometriosis as a differential diagnosis? If not, this will add one more delay, and which is called doctor's delay. So far, most textbooks in pediatrics do not mention endometriosis at all. And societies for pain in children do not include links to endometriosis on their homepage as well. And of course, the family medicine, the orientation of the general physicians has seldom chapters and emphasis on endometriosis, and not only emphasis, discussion about different dilemmas regarding diagnosis of endometriosis. Sorry, there is some overlapping with the presentations. I may have to stop screen sharing and talk. I think there's something wrong with my slides. So I'll rest of the slide I may have to talk on my own. So yeah. So the next controversies or the delays which happen. Please unmute all the participants. Unmute yourself. Mute yourself, please. Okay. So regarding hormone treatment, there are different delays. Like one is which hormone to prefer. So this is again the challenge that often the GnRH analogs are being chosen as therapeutic.
Sorry, we cannot see the slides.
I say there is some difficulty with the slides, so I have to talk without the slides. So that's okay for me. I cannot. I think at the last moment something happened to the slides, so I could not save the last slides. So I'll go on talking on my own. Please bear with that. So, but what we see that the different hormones which are prescribed for endometriosis, the age-old oral contraceptive pills, progesterones in the form of tablets, injection, intrauterine system, danazol, of course, including GnRH analogs, newer drugs like Dynagest, Electrolix. So these are, though there are several researches, but it is not proven clearly that which is superior to another. So giving drugs like higher price is sometimes a challenge for the patients, as well as the symptoms related to this. We know the symptoms of danazol, long-acting GnRH agonists. This is a challenge again for hormonal treatment. And then we know the newer drugs, they are though they are claimed to be and sometimes proven to be better drugs, but often when the newer drugs come, they are not being tested for long-term use, because these hormones for endometriosis are meant to be long-term use. So even in the researches, we need to consider this, that we have to always test the newer drug against the age-old drug, not the new versus new. It should be always tested with age-old proven drugs for treatment of endometriosis. So that's another challenge. And it has to be remembered that this is a benign disease, though chronic, but benign disease. And the treatment of endometriosis should not be more troublesome than the disease itself, which often happens. So sometimes the patient doesn't come, or we are not enough careful, and the appointments are given in much later date, or patient comes back after sometimes when it is very complicated, or she is suffering from some side effects. So this is again a big challenge regarding hormone therapy and the conservative therapy, because they may need close follow-up for the progression of the disease, improvement of the symptoms and the condition, as well as need for add-back therapy for the side effects. So the appointments and the contacts should be close enough. The literature suggests it should be between 3 to 6 months. That's ideal. And with the it was before, but with the during the era of COVID-19, we learned about telemedicine. So these patients can be taken care of by telemedicine services and over telephone calls. And there should be very good counseling services for these patients. And we can add to our team different paramedics, including nurses, like we do in long chronic diseases like diabetes and many others. And again, if the treatment of pain relief fails, despite apparent effectiveness of a menstrual period, we have to reconsider the diagnosis of endometriosis. This is again a challenge, because we are treating her. She is maybe relieved of pain. I mean, there is suppression of menstruation, but she is not relieved of pain. So there are many different ways of dealing with this, and that has to be dealt with. So we have to go back, thorough recheck-up for the diagnosis, maybe an additional one, or maybe the diagnosis can be reviewed to come up with some other diagnosis. And for the we can even consider about the very developed, now there are many countries where the multidisciplinary pain team, which can help us to go for the diagnosis and treatment of these patients. Again, it should be kept in mind that there can be sidetracks. Endometriosis can be an incidental diagnosis, but there may be some other drug, other diagnosis which is coincidental. But it is said that this basically helps sometimes for the patients for the treatment of endometriosis, because even for the treatment of many other conditions, we know that the endometriosis improves, and the patient often are not aware about the condition at all, because that has been automatically taken care of for the treatment of other disease. The next challenge is which are related to infertility. Subfertility is a common in endometriosis, and this is a burden added to the physical pain. Patients should be encouraged and told that the majority of the women with endometriosis have normal or close to normal fecundity. It has for decades been determined that medical treatment does not increase the fertility rate, whereas laparoscopic surgery may improve pregnancy rates. So these are proven, and I am talking over from different literatures. The coexistence of pain and infertility is therapeutically challenging, as many hormonal treatment for pain also act as a contraceptive. So there are, again, different issues. Number one is the endometriosis, the pathology itself, the pain, the dyspareunia resulting from endometriosis, and again, the infertility or the suppression of fertility by different drugs which we are using. So it's a complex issue of subfertility and endometriosis, and a close contact between the general gynecologist and infertility centers are often desired. We can combinedly develop the treatment plan and take into account of the patient's need, of course. IVF often is said, the ARTs are often said a rescue, and there are studies which shows that this often helps, and the rate of success of ARTs are similar in both the cases. Another important thing is information and media. There are many others, but I'm going to touch a few only. So information and media, when the young girls, especially who are very often know the know-hows of the internet technique, so often they go to the internet. So we must, before they go into the internet, be informing them quite enough with confidence, and bring them into confidence that what is endometriosis. Because in the internet, they get so much information. This is not only for endometriosis. We often see our patients confused, overreacting to the treatment. They are challenging the treatment. That is good in one sense, but they are often confused and mistracked. So this is very important. This brings this generous distress and anxiety. Knowing this is an abnormal growth means association with cancer. So this is often written in the internet. Repeated verbal information from the health providers is essential and should be combined with the written information. The internet is an enormous source of information with more than 8 million hits just for endometriosis a day, but with a quality which ranges from excellent down to confusing and erroneous, as I have mentioned. So health professionals should warn about the risk of outdated and inaccurate information online, which could delay proper treatment, could be expensive, and then dangerous. Patients Association have a great responsibility to spread balanced and well-documented materials. And we should be careful about this, and often check this internet's country perspective, so that the patients are less confused and they get the proper treatment. Those of us who are professionally engaged in endometriosis are often contacted by journalists who have heard about this mysterious disease and want to make an article or a program. This is a golden opportunity to spread information, but often this even leads to a struggle with the journalists and the patient society who want to present the worst case to show the seriousness of the disease and associate it with incapacitation and hopelessness. So we have to be cautious about it. Yesterday we had a very good policy session where journalists and general public were there. So these are the opportunities where we should take care of. And as I have already mentioned, that we should not let the people know about this disease for earlier diagnosis and taking care of our young girls and young adults. But at the same time, we have to think about that so that they are not misinformed and they should not be confused for the diagnosis. Medical experts on endometriosis and patient groups should work together to disseminate most updated and actual information and for exchange of views. So in conclusion, endometriosis affects 6 to 10% of women of fertile age, sometimes maybe more, and symptoms can already start in teenagers. There is a considerable diagnostic delay in diagnosing the disease, especially in young patients. Continuous combined oral contraceptives or progesterone may be given as a first line of drug, depending upon the situation, because this is it takes a long time to treat these patients. We have to think about the expensiveness and also the convenience. Hormones do not improve fertility, but we have to take care of the conditions which we have mentioned regarding the problem of infertility with endometriosis. And information about typical signs of endometriosis should be given to the adolescents, to the population in general, and to the healthcare providers at all level of care, especially at the primary level of care. And even sometimes, not sometimes, to our paramedics, so that they can pick up and refer the cases. With this, I thank everyone for the patient hearing. And once again, thank the organizer for giving me this opportunity. And I wait eagerly to hear from Dr. Mahapatra. Thank you so much.
Thank you, Madam, for your excellent presentation and give us a direction for early diagnosis of endometriosis and its prevention, and to save our young adolescent generation from the dreadful complication of this disease. Thank you, Madam. Now, I am requesting our second speakers. Hello. Dr. P. Das Mahapatra, Director, Spectrum Clinic Endoscopy Research Institute and Founder, Secretary General, Endometriosis Society of India. He will talk on quality of life before and after endometriosis. Sir.
Hello.
Das Mahapatra, sir.
Hello, good morning, everybody. Good morning. Can you hear me?
Yes, we can.
Yes, sir, audible.
Yes. Can I share my slides now?
Yes, sir.
Okay. Can you see my slides?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
Yes, sir. We are
Okay.
seeing. Just give the slide share, sir. Slide share.
Yeah, I've done that. Okay.
Perfect.
Now I'm going to talk about the quality of life before and after treatment of endometriosis. Now, to be honest, ladies and gentlemen, I am yet to wake up from my, the hangover from our Durgotsav, the festival of worshipping Durga, which finished yesterday. However, ladies and gentlemen, I did this prospective study with a team of doctors and my assistants, Omyokanti Majumdar, Arun Majumdar, both of them are medical doctors, Sudeshna Boxi, assistant researcher, and Indrajit Moitro, a statistician. Now, what is quality of life? It focuses on overall well-being. It is the degree to which an individual is healthy, comfortable, and able to enjoy events. Now, we should understand, ladies and gentlemen, that by this 2021, the health standard and life expectancy have improved a lot. And the indication of good health has become more holistic. Health-related quality of life is a multidimensional concept encompassing physical, psychological, and social aspects. Now, we understand that endometriosis is a chronic and incurable disease, and the quality of life in women with endometriosis is a growing concern, increasingly voiced by health professionals, patients, and other groups. We also know that triad of dysmenorrhea, dyspareunia, and infertility leads to physical, mental, and social stigma. Significant reduction of quality of life by the disease process and its effects on the therapy. The quality of life is also disturbed by the therapy we do, be it medical or surgical. And the role of understanding family members, partners, and physicians and support group is very important. You see, for over decades after decades, we concentrate on the symptoms of endometriosis and the relief of symptoms. But for the last 1 decade, we are concentrating on the improvement of quality of life. Why quality of life? It is a measure of your success of treatment. It facilitates the overall evaluation of the patient. It helps auditing, comparison with other researches, and it provides better treatment options. Now, how to assess quality of life? Quality of life is a subjective phenomenon. So we cannot measure by MRI or ultrasonography or even by clinical examination. You have to keep faith on the patient. You have to trust the patient's symptoms and whatever she writes on the paper. But that is why the questionnaire is the best, if not the only method of quality of life assessment. As we have heard from Samina Chaudhary in the morning, that she sent questionnaire to all the schoolgirls. Now, almost every institution and the organization has their own questionnaire. Just to mention few, the international reputed ones are the E-Impact Quality of Life, Euro Quality of Life, EQ5D, SF36, EHP30, EHP5, and EPQ, the one we used. It is called the Endometriosis Patient Questionnaire. Each scale is transformed into numerical data from 0 to 100. 0 means the best health and 100 means the worst health. Now, I'd like to discuss or mention some of the points on endometriosis health profile, EHP 30/23. It has 2 parts. First part is the core questionnaire containing 5 scales, and the second one is the modular part containing 6 scales. Now, the different items on pain, emotional well-being, and intercourse fertility improvement were considered, and the 2 scales of social support, control, and powerlessness was also taken into consideration. So it is very important that we probably know about this. Now, the good thing about this EHP 30/29 is that it exhibits good reliability, validity, and interpretability. And the other point is that it is recommended by ASRM and ESTRA. But the question is, it is 2 long questions. And questionnaire evaluation time to be shortened to use outside consultation. It takes out the 10 to 15 minutes. But I think in a busy clinic, it is very difficult to be filled in front of the consultant by the patients. You are unable to give 15 minutes time to the patients to fill in front of you. So you need to have an assistant who can actually get these forms filled up by the patients. EHP 30 is not appropriate for use with general population. And it does not allow to calculate a single aggregated index, but 11 dimensions that can vary differently. The other question is EHP 5. It is being derived from EASB 30 and is a shorter form, and it fulfills a role in everyday clinical practice because it is a shorter form. It can be used by the consultants in the clinic room. But it is a generic instrument particularly useful for epidemiological studies since it allows comparison of management or population regardless of the disease. It allows comparison across diseases and between patient scores and those of the general public. Now, what we have done in our clinic during this 5-year period, we divided 2 groups, 250 in each group, 1 women for medical therapy, but all the cases were confirmed diagnosis by laparoscopy, and we included only stage 3 and stage 4 diseases. The medical therapy means we treated them with diagnosis 2 milligrams daily. How did we select the patients? Medical therapy group was selected on the basis of patient's choice, pregnancy not desired, recurrent disease, young women, and ovarian endometrioma less than 4 centimeter diameter. The age group was 18 to 45 years, and we used the endometriosis patient's questionnaire EPQ in English was used. English, you see, probably I don't know whether you are aware that we have 22 important well-spoken languages in India, unlike Bangladesh where there is only 1 language, that is Bengali. So I had the opportunity to practice in Calcutta, in the heart of the Calcutta, where 90% of the patients of mine are conversant with English. So that's why we have taken the English. The regional language of Bengali is not taken into consideration because, Calcutta is a place where at least 5 languages are being spoken. Whereas English has become a common language for most of the patients I see in my clinic. Each patient was called for follow-up every 6 months for physical examination and to fill the patient form and the score noted. But those who could not attend, we have a recall system. We call them to reappear for examination. If they don't come, then we take the information by telephone. This is a form we use, that is a bizarre form. You can see there's so many points to be considered. I'm sorry, it's a very fuzzy one because the photograph is taken from the forms itself. Now, see the result. The medical therapy, we have 250 patients and 170 patients responded well after 1 year. So 250, 170. Hello? Hello?
Is hearing, sir? Hearing, no problem.
Yes, sir.
Okay. So out of 250 patients, 170 patients after 1 year remained well, and 160 patients after 2 years, 155 patients after 3 years, and 152 patients after 4th year, and 5th year, 148. So you can see that the response is becoming less and less as the year passes, and by 5th year, we got 148 who had an improved quality of life. And the red square shows the scoring system. Now, when he did the laparoscopic surgery, it is laparoscopic conservative surgery. But these are the associated factors we have seen associated with endometriosis in stage 3 and stage 4. Adenomyosis was found in 48% cases. Infertility was 48%. OMA plus peritoneal endometriosis. And OMA is 12% only. Solitary OMA was found in only 12% cases. And deep endometriosis is 31.2%. Again, selection of patient's choice, severe persisting pain, OMA more than 4 centimeter, infertile patients, and failed medical therapy. Now, this is very interesting point. You say no improvement in quality of life even after doing a long laparoscopic surgery in 8% cases. So the initial no response was obtained in 8% cases. However, good news is that 92% had improvement in 6 months. Fertility enhancing pregnancy had successful pregnancy outcome in 36%, which is equal to IVF treatment. However, the recurrence within 5 years was 30%, and perioperative serious complication is 2%. That is very important because it is a very difficult surgery. As you can see from here, the deep endometriosis involving the rectum, the uterosacral ligament, and the pouch of Douglas, and you can see that whole area is endometriotic. It is being excited gradually. This lady also had endometriosis of the ureters, so we had to deal with the ureteric endometriosis at the same time. Now, this is our surgical report. You can see that adenomyosis was 27%, infertility, OMA, peritoneal endometriosis, OMA, deep endometriosis is 17%, and 7% was for solitary OMA. Now, if you see that the results is pregnancy 36%, serious complication 5 in number, there has been 2%, and then improvement after 6 months is 92%.
Hello, sir.
But
Hello.
Yes.
Good morning again.
Good morning. Dr. Tushar just added the name of the presenters.
Okay.
Yes.
Shanmin, unmute karo.
Recurrence at 5 years, that is 30%. The quality of life improvement after the surgery, you can see that 12 months improvement was 88%. 24 months it is 80%. But however, this is gradually declining and it is 70% after 60 months. So that means initially what happens in surgery, you get initial and early improvement of symptoms or improvement of the quality of life from the next period after the post-operative pain and morbidity is over. So the patient experiences benefit from the next period. Whereas in medicines, you have to wait a little longer. So we compared the two studies, two results. You see that this is the medical therapy results and this is the surgical therapy results. You can see the 88% was quality of life improved after 12 months, or 68% with medical therapy. And both this treatment module, actually the quality of life decreased to 70% in surgery and 59 or almost 60% in medical therapy. Now, why it is happening? So what we have learned from these studies, surgery is a better option to improve quality of life because early improvement from the next cycle. You get immediate effect of surgery. But quality of life declines from 88% to 70% over a period of 5 years. Recurrence is 30% in 5 years, starting from second year onwards. Pregnancy outcome is 36%, serious complication 2%. But however, ladies and gentlemen, the last line is very important, that we need to have a dedicated surgical team to do this surgery. And that means we invite that there has to be surgical skill, which is a recommendation by all the societies. In contrast, what the medical therapies is, anybody's game. Anybody can prescribe this medicine. Takes 6 weeks to 12 weeks to initiate the benefit. It doesn't work instantly because the medicine has to work slowly. And so immediate action or early action is not possible. Quality of life again declines from 68 to 59.2% in 5 years. Now, Rita, why there is reduction of quality of life in medical therapy? Patient is having the same degree of disease, patient is having the same medicine continuously. Probably, it is the adverse effect of the medical therapy that is diagnosed. Diagnosed is responsible for many adverse effects like cerebral problem, headache, psychological disturbances. Even few of my patients felt like committing suicide with diagnosed. No further improvement may be due to resistance. I am beginning to see that one type of drug you use for 5 years, 2 years, 3 years, and suddenly they become resistant. The patient says, doctor, these medicines are not working for me. So we need to change to another progestogens. Now, complaints with the medical therapy is very unpredictable. It is not surgery that you do one time and the result persists for 5 years. Recurrent cost is a concern because it's expensive medicine. I know the surgery cost a little higher at the beginning in one-time expenditure, whereas in medicines, you have to keep on spending money year after year. So, ladies and gentlemen, with this, I finish my talk, but with the prayer to our goddess Durga, who has a spear which is similar to our surgical skill to kill the demon, the Asura, the demon of endometriosis for women. Let us develop some kind of surgical tool to remove all the disease, or we can use the lion here to use a medical therapy, which I was told in the early lectures that we are still in the process of developing newer and newer drugs. Maybe one day we'll be able to discover a drug which can be sprayed on the endometrial tissue in the pelvis and the disease will disappear permanently. Ladies and gentlemen, with all these hopes, I finish and thank you, everybody. I thank my workers who worked with me and also the organizers who invited me to have this lecture. Thank you very much again.
Thank you, sir, for your excellent presentation and for giving us a overview of treatment, comparing the surgical and medical treatment. Now, it is the time for question and answer session. There is no question in the chat box.
Can I ask a question about the?
Sir, do you want to? You have time for chairperson? I have one question to Professor Ferdowsi, madam. Often we have to face some young patient with large endometrioma, where there is basically no roll-up or little roll-up medical treatment. And after surgery, often this patient come with recurrent cyst. What is your suggestion for younger gynecologists regarding the management of this case?
My question also was a similar one only to both the speakers. Suppose young girls before marriage, around 20 years, if they come with a big endometrioma, will you do the surgery or as or medical marriage, which will be the first line? And thus, sir and Ferdowsi madam, thanks for that wonderful lecture. And I just want to know both the opinions regarding the quality of life and regarding the everlasting challenges of having endometrioma in young girls.
Ferdowsi madam.
Thank you so much. Thank you. So the question itself is a big challenge.
Yes.
And I think there is no one answer for this. We know this. We know the guidelines. The clear-cut answer is the big endometriosis should be treated with surgery. But the thing is, often it happens that the patient cannot afford or want to delay somehow, especially in our perspective, may not be in the developed countries. So in that case, we can go on with some medical treatment, but I think the treatment of choice is surgery, and my dear friend and the other, Dr. Dash Mohapatra, will be the right person to answer this. So I refer this to the other. Thank you.
Can I answer this question?
Yes, sir.
I think I am governed by two things. One, what is the size of the endometrioma? If it is more than 4 centimeters, I do not wait further, I do laparoscopic surgery. If it is less than 4 centimeters, I try the medical therapy with anesthesiologist first, and then follow them up every 3 months. Now, two things may happen. Either the cyst might reduce, and secondly, it may not reduce at all, and it may not improve the symptoms of pain. If it fails to reduce the size or it fails to improve the pain, then we have to call her for surgery. So surgery has a better place if the cyst is more than 4 centimeters. which usually do not respond with medical therapy. Less than 4 centimeter, we have seen on the records in the literature that 4 centimeter or less, it responds well with danogests, but not in every patient.
Thank you, sir. I have another question for you. That is, patient having pelvic endometriosis suffering from severe chronic pelvic pain and dyspareunia, and even after surgery, like hysterectomy and salpingo-oophorectomy, symptom persist, and how to improve the quality of this patient in this patient? What is your suggestion?
Well, first of all, why she is complaining about hysterectomy and BSO? I always subject the patient for MRI to know if we have left out any disease or residual disease. If there is residual disease, especially in the rectovaginal septum, which is possible in this case because she had dyspareunia. So that needs to be removed by surgery. Unfortunately, it's very unfortunate for the women that she has to undergo again the surgery, maybe third or fourth, whatever it may be. If we do not find anything, any evidence of deep endometriosis, we can give medical therapy for long. Simplest thing is to give, not danogests, which is very expensive. It is not necessary. Just give it, Depo-Provera or medroxyprogesterone acetate for long, and you don't have to bother about spotting because there is no uterus and it works well. Maybe for 3 years, 4 years, 6 years, she can carry on taking this medroxyprogesterone.
Thank you, sir, for your suggestion.
Yes.
Madam, I think now we have Dynogest is there and people are started using, even though it is a costly drug, but there are reports of people using it for more than 2 years. But how long maximum, there is no clear-cut evidence of how long can we use, especially in the young girls. So any personal experience or anything you can tell about Dynogest?
I have been using for more than 6 years.
I think the evidence now says that it can be used safely for more than 4 years, around 4 years. So that has been established already. And Dr. Mahapatra may be having experience for 6 years as well.
Yes.
So this is a good drug. If the patient can afford it, then I think this is the
well,
drug.
It is not an ideal drug, but it is the drug, the best drug we call it at present. Because as I said, a couple of my patients felt like committing suicide. With these drugs used for more than 3 years.
And another important thing is the spotting, So that's sometimes.
Spotting is not that. Spotting is not going and that can settle down, that can be treated by addition of other drugs. But the most important is the psychological effect, the headache. Headache is a very great problem, and some patients tend to discontinue. That's why compliance is very important for this medical therapy, because they have to continue these medicines without any interruption. It is not like GnRH analog or anti-GnRH, which can be given every month or every 3 months.
So the role of follow-up is very important. Time to time follow-up is very important because.
Oh, yes.
Not only the progression.
They become your permanent patient. They become your permanent patient.
Also for the side effects as well.
Yes.
May I ask one question? What is your experience about using the oral contraceptive pills?
Well, I have become against oral contraceptive because it contains estrogen, maybe 20 micrograms. But we have now recording cases who had oral contraceptive for ages without the presumptive diagnosis of endometriosis being confirmed. We found they are now appearing with a very advanced disease. The reason is it definitely improves symptomatic relief. It gives him symptomatic relief with oral contraceptives because of the anovulation. But we call it the still water runs deep. Patient does not get the symptoms, but the actual disease process runs faster inside. So we should be very, very careful before we prescribe oral contraceptive for this patient. I only use in cases where my diagnosis is not confirmed and it is associated with PCO. A patient is having oligomenorrhea, wants to have regular period. I am not sure whether she has endometriosis or not, and she is reluctant to have a diagnostic laparoscopy. Then I sometimes use oral contraceptives. Otherwise, not as a treatment for endometriosis.
That's why there were questions that the newer drugs should be tested. We must have enough research on these issues as well.
Oh, yes.
Yeah, because the age-old oral contraceptive is helping us for a long time, number one. Number two is on the controversy of using estrogen in case of endometriosis. But I think there is not enough evidence for us to answer very clearly, should we or should we not? Thank you.
Thank you, Madam. Thank you, Professor Firdausi Begum, Madam, and P. Das Mahapatra, sir, for their excellent presentation and evidence-based discussion. Now it is the time for chairperson. I am requesting Professor Dr. Farooq Jamal, sir, to give his comment on the presentation of Professor Firdausi Begum. Professor
Thank you
Farooq Jamal, sir.
Professor Nasreen. First of all, I'd like to extend greetings to all the friends and particularly, first of all, the organizers. Why I say, first of all, organizers, because this is an excellent webinar with a very elaborate program. And I don't really think there would be any aspect of endometriosis which probably has not been covered by this excellent program of 2 days from morning till evening. That great program. And hats off to Professor Samina Chaudhry for having spearheaded this, and Dr. Sharmeen Abbasi for her untiring efforts in contacting all the delegates, and I'm sure that she hasn't had any sleep during the last fortnight or so. Now, my warmest regards to Professor T.A. Chaudhry. He's amongst the senior most amongst us. And this gives me a particularly, I feel so delighted to have seen Dr. Mahapatra after so many years, and Fassi Lewis. Both the gentlemen, I have had the privilege of making friendship for last so many years. Fassi Lewis, I know for the last 8 years, and Dr. Das Mahapatra, almost 20 years. So it's such a player. And of course, all the senior faculty from Bangladesh and others. It's a great occasion. So instead of commenting on the endometriosis, I'd like to comment on this aspect of the webinar. And secondly, I think that this has been a great educational and must be a great educational experience for our younger colleagues from the point of view of organizing such conferences, such webinars, such seminars of awareness for public as well as for healthcare professionals amongst ourselves. And a little bit about the presentations also. Professor Firdausi Begum's topic was a great topic about the everlasting challenges, which she has very nicely elaborated starting from the 70s till 90s and beyond, that somehow the diagnosis still eludes us, this being so common a problem that it takes so many years before we make a diagnosis. And she enumerated the pain and the various aspects of the challenges that endometriosis poses besides diagnosis. And it is kind of the same 3 delays that we came across in maternal health morbidity, that it is delay on the part of the patient, delay on the part of the doctor, and perhaps the 3rd delay would also be there of instituting treatment. And then it was such a refreshing thing to come across the original study of Dr. Das Mahapatra. I mean, this is excellent. The follow-up that he has carried out for 5 years, and obviously that gives him the authority with which he was speaking, and the conviction with which he can pronounce his results and tell about the efficacy of the treatments. excellent presentations. And once again, congratulations to the Endometriosis Society of Bangladesh and Professor Samina Chaudhary and her organizing team. Once again, a very warm regards and greetings to all the friends. Thank you very much.
Thank you, sir, for your encouraging word and comments. Thank you again. Now it is the time for Fesi Luis to comment on the presentation of Dr. P. Das Mahapatra.
Thank you once again for inviting me. It was a wonderful experience to be with Endometric Society of Bangladesh, and it is nice occasion to be, as Farooq sir told, to be seeing even virtually after many years those who have been known for many years, like Das Mahapatra sir. Even though because of COVID we are not meeting, even though in India, and Farooq sir and Firdausi madam, which as for last 8 to 9 years, right from the Suffolk time, we have been in constant touch. And coming to the talks, both the talks was very good. And the topics selected by the committee, especially thanks to Dr. Sharmin Abbasi for the wonderful effort she has been taken. And the talk by Das Mahapatra sir about none would have thought about the quality of life, whether you take the treatment or not the treatment, whether you take the medical treatment or the surgical treatment. And that has been really highlighted here, and original work has been, we were able to hear. So that will give us an insight to the, as being gynecologists dealing with endometriosis, how we have to, when we just more than just telling about one treatment of medical management or surgical treatment, whether it is laparoscopy or open surgery, whatever it may be. So how far that will improve your quality of life, whether you are married, whether you have infertility, your family is completed, those things we have to clearly look into it. That has been really highlighted. And I hope this will be really enlightening to that to all the audience here. Thanks for inviting, and thanks for the wonderful talk and academic piece.
Thank you, sir. Thank you for your nice remark and interactive discussion. Thank you again. Now, I am requesting Dr. Fozia for the next part of the session. Dr. Fozia.
Thank you, Dr. Samin Abbasi, for sending me emails after emails. They are reminding me.
Dr. Fozia, for your concluding remark. Dr. Fozia, nine.
I'm audible?
Yes, you are audible.
It is my pleasure to thank the honorable chairpersons. My thanks to the speakers for their excellent deliberation, which has enriched our knowledge enormously. Thanks to moderator. Thanks the audience for having with us. Now over to Dr. Sanjida Mahmood for the next session.
Thank you. Thank you for the one of the nice session. Thank you very much.
Thank you. Ladies and gentlemen, should I start?
So
we're audible. Bismillahirrahmanirrahim. Ladies and gentlemen, participants from home and abroad, a very good day to all. I'm Dr. Sanjida Mahmood, welcoming you all to the first virtual international scientific conference of the Endometriosis and Adenomyosis Society of Bangladesh. This is a panel discussion session. We all know that endometriosis adenomyosis may not only make the pregnancy difficult, it also have risks to the serious pregnancy complications. Today, we are very much honored to have Professor Firdausi Islam, Professor Firdausi Islam, Professor, Department of Obstetrics and Gynecology, Popular Medical College Hospital. She was also ex-president, departmental head of Obstetrics and Gynecology Department, DMCH. And Professor Ifatara, Professor, Department of Obstetrics and Gynecology, Popular Medical College, as a chairperson of this session. This session will be moderated by Professor Tabassum Parveen, Professor Maternal Medicine Department of BSMMU, and also General Secretary of Fetal-Maternal Medicine Society of Bangladesh. Now I'd like to hand over the microphone to Professor Tabassum Parveen to continue the session, our moderator of this session.
Thank you, Dr. Sanjida. I am requesting Poppy to show the slide of Professor Kohinoor Begum, Madam. Please, are Poppy here? Okay. Am I audible, Sanjida?
Yes, madam.
Yes, madam.
So I'm starting. Dear audience, you all will agree with me that with increasing in frequency of adenomyosis and endometriosis in recent years, increasing number of pregnancies are coming up and becoming our concern. However, the impact of these conditions on the outcome of pregnancy is still not very much clear to us because few studies and research done in this field. This session is designed to know the expert opinion on the issue that is a bit different that is normally discussed on subject of adenomyosis and endometriosis. In first part of this session, there is a keynote speech by Professor Kohinoor Begum, Madam, on impact of endometriosis and adenomyosis in pregnancy. And in second half, there will be panel discussion. Dear audience, it's really my great privilege to introduce the keynote speaker, Professor Kohinoor Begum, Madam. She graduated from Sher-e-Bangla Medical College in 1975, passed FCPS in Obs and Gynae in 82. She served as the head of the department in leading institutes of Bangladesh like Dhaka Medical College, Sir Solimullah Medical College. She was the past president of EASB. She is recipient of FIGO 2013 award, and her involvement in Bangladesh College of Physician and Surgeon is well known to all of us, where she is presently acting as counselor as well as vice president. Actually, it's really beyond my capacity to introduce her. On behalf of all, I'm just conveying our salam and wholehearted respect for Madam. So dear audience, let's welcome a very lively teacher par excellence, trainer, extraordinary human being, our mentor, Professor Kohinoor Begum, Madam, for her keynote speech. Madam, please.
Dear Tabassum, আমি slide share করি।
জি, madam.
কপি তুমি করে দিবা নাকি? কপি তুমি একটু করে দাও স্লাইড শেয়ারটা।
কপি আছো তুমি? কপি
এটা দেখতে পাচ্ছি না কেন?
ম্যাডাম শেয়ার স্ক্রিন
ম্যাডাম একটু সেখানে গেলাম তো কিন্তু আমি পাচ্ছি না। এই সামিল হ্যাঁ কপিকে বলো কপি একটু করে দাও।
ম্যাডাম
হ্যাঁ করে দিছে থ্যাংক ইউ Thank you, Dr. Tabassum, for your nice introduction. My topic is impact of endometriosis and adenomyosis on pregnancy outcome. Okay, next slide now. The prevalence of endometriosis, you know, 1 to 2% of all the women of reproductive age, and 6 to 20% of the women with adenomyosis also suffer from endometriosis. The endometriosis and adenomyosis are both associated with chronic inflammation and not only cause disorders including dysmenorrhea, chronic pelvic pain, and infertility, but have also recently been implicated in a range of obstetric complications. Next. How does endometriosis affect fertility? The correlation between the endometriosis and infertility is well documented, with monthly fecundity reported to be 0.2 to 1 compared to couples without endometriosis 0.07 to 2 per month. Getting pregnancy when the patient have endometriosis is a bit difficult, but around 7 in 10 women with mild to moderate endometriosis conceive without treatment. Next. A mild or minimal endometriosis, how it causes infertility is not known, especially in cases where ovaries and fallopian tubes are normal. But there are some effects on reproduction could be noticed. Number one, a toxic effect on gametes, embryo, and impairment of the tubal motility. The endometriotic implants secrete endometric implants secrete pro-inflammatory cytokines, that is interleukin B, 8, 6, and T1 necrosis factor, estriol, and progesterone. Next. Which attracts macrophages, vascular endothelial growth factor, and interleukin 8, thus creating an inflammatory state impairing fertility. An abnormal follicular environment high in cytokines increase the rate of apoptosis in granulosa cell and an enhanced ability to phagocytosis of the sperm by peritoneal macrophages. How moderate to severe endometriosis affects the reproduction. In addition to above mentioned factors, there is some mechanical factor like an impairment of the oocyte cheilies owing to pelvic adhesion and endometriomas, an impairment of the tubal transport, and blockage of the sperm migration. Adenomyosis can influence the uterine peristalsis, the transportation of the sperm in the uterine cavity, and embryo implantation, finally, that leads to reduced fertility. Next. Effect of surgery on fertility. The laparoscopic treatment of minimum and mild endometriosis have been associated with a small but significant improvement in the pregnancy rate. In a large study, it has been shown 29% of the women who had their endometriosis treated conceived within 9 months. But in comparison to only 17% who do not treat it during the laparoscopy. Next. The treatment of moderate and severe endometriosis, either by laparoscopy or laparotomy, increases the crude spontaneous pregnancy rate by 57 to 69% in moderate cases and 52 to 60% severe cases when there is no other cause of infertility in the women. The reduction of the ovarian reserve and chances of ovarian failure is possible where the ovarian tissue have been destroyed by extensive surgery. Next. The medical therapy, there is no evidence that medical therapy of the endometriosis improve the fertility, but instead, the medical treatment before and after surgery may delay unnecessarily further fertility therapy. Next. Endometriosis obstetric complications. Numerous studies have noted an increase in the rate of wide variety of obstetric complications, including premature rupture of membrane, preterm delivery, abnormal placental positioning, small for gestational age infants, and preeclampsia in endometriosis group. And it depends, the severity depends on, complication depends on severity of endometriosis and the rate of ART used to fertility. Endometriosis obstetric complications is studied in 2017 by Zulu et al., including 1.9 million women. They showed that incidence of a small, abnormal placental position, SGA infant, and cesarean delivery were higher in pregnant women with endometriosis, but not found no increase in the incidence of hypertensive disorders of pregnancy. But effect on ART. The Burnett et al. A meta-analysis on 22 observational studies showed that women with endometriosis have poorer IVF outcome than with women with tubal infertility. The fertilization rate, 17% reduction in the stage 1 and 2 endometriosis, but implantation and clinical pregnancy rate are much lower, 21% reduction in stage 3 and 4. There is a comparative study of ART outcome endometriosis versus adenomyosis. Though the two groups have same number and similar quality of embryo transferred, in adenomyosis group, the clinical pregnancy rate is lower. They had a significantly increased spontaneous abortion rate, obviously declined implantation rate, and decreased birth rate in comparison to the patients with endometriosis. Severity of endometriosis and pregnancy. Endometriosis can be categorized into 3 distinct subtypes like peritoneal, ovarian, and deep infiltrating endometriosis. Despite some variation between the studies, many studies have found that in deep infiltrating endometriosis, there is increase in the incidence of the rate of preterm labor, SGA, abnormal placental positioning, preeclampsia, and other obstetric complications. Next. Now come the adenomyosis. There are different studies which shows there is increased incidence of late spontaneous abortion, cervical incompetency, PET, preterm prom, preterm birth, HG infant, fetal malpresentation, placental malposition, increased incidence of cesarean delivery, PPH, and uterine infection in adenomatous group. A study by Hiroshi Tamura from 65 facilities, they have shown the complications of pregnancy. They included miscarriage. Before 12 weeks, the percentage is 14.8%. After 12 weeks, it reduces to 9.9%. There is chance of preterm labor, fetal growth restriction, pregnancy-induced hypertension, intrauterine infection, cervical incompetency, preterm prom, placenta previa, atonic bleeding, intrauterine fetal death, uterine rupture, and abruptio placentae. This is a hypothetical model of pathophysiological involvement of adenomyosis in the obstetrical complications. If we consider adenomyosis, there is chronic inflammation of the myometrium, which is the main trigger point of having preterm labor, second trimester miscarriage, and other pregnancy complications, and added symptoms by impaired placental perfusion. Next, the clinical inflammation in the myometrium, chronic infection myometrium, caused by the adenomyosis may be the central driving force in developing the obstetric disorder, including preterm birth, abortion, placenta previa, preeclampsia, SGA. Insufficient placental perfusion associated with adenomyosis may also trigger the placental dysfunction, leading to such obstetric disorders. Next. Though exactly we cannot know the correlation between adenomyosis and the outcome, but there are some factors which can be focused. There is a recent attention have been focused on thickening and disruption of the junctional zone in adenomyosis causes disturbance in early placentation due to incomplete spiral artery remodeling, resulting in placenta insufficiency and complications of pregnancy like PET, PE, late spontaneous abortion, preterm delivery, and HG infant. Number 2, chronic inflammation in the myometrium may exert a direct effect on the implantation and placentation. 3, implantation failure is associated with the abnormal placental position and early incomplete placentation. So, uteroplacental perfusion failure due to presence of adenomyosis might also trigger the placental ischemia associated with subsequent development of PE and leading to more infants with SGA. 4, it is thought that adenomyosis may increase intrauterine pressure during pregnancy due to the poor muscular elasticity and the insufficient expansion of the myometrium in accordance with the growing uterine content. So, this can contribute to cervical incompetency, late spontaneous abortion, and preterm labor. Next. Now the size of adenomyosis and pregnancy. The miscarriage rate over 12 weeks and the cervical incompetency rate are higher in larger size of adenomyosis, more than 60 millimeter group. Except miscarriage and cervical incompetency, there are no significant difference in the other pregnancy complications depending on the size of the adenomyosis. Next. Type of adenomyosis. The rate of PIH, premature delivery, and intrauterine infection are higher in patients with diffuse type of endometriosis in comparison to focal type of endometriosis. The rate of other complications of pregnancy didn't differ statistically significantly between these two groups. Can endometriosis cause miscarriage? Yes. A large systemic review found that endometriosis may increase the spontaneous miscarriage rate by about 80%. Next. The possibility of a miscarriage in women with stage 1 and 2 endometriosis was defined to be about 42%, whereas the same for the women stage 3 and 4 was termed to 31%. Why there is discrepancy? Because mild endometriosis has the highest chance of causing inflammation within the woman's body. This inflammation, in fact, could be involved with the miscarriage taking place. Next. The patient's adenomyosis and miscarriage. The patient with adenomyosis also show high level of inflammatory substances such as increase in prostaglandin, which have been suggested as a potential cause of uterine contraction. In addition to prostaglandin, the production of pro-inflammatory cytokines, including interleukin, tumor necrosis factor, and epidermal factor, is increased in the endometrium of the patient with adenomyosis. A recent report showed a significant increase in the myometrial stiffness in patients with adenomyosis, which increased intrauterine pressure in pregnant women. Thus, a combination of uterine contraction caused by the chronic inflammation and a high intrauterine pressure caused by myometrial stiffness might be the factors that contribute to adenomyosis-related miscarriage and cervical incompetency. Next, adenomyosis and IVF. For adenomyosis patient undergoing IVF, the oversize of the uterus, tissue necrosis factor, and other toxins due to chronic inflammation in the endometrial glands all have adverse influence on the endometrial implantation. Therefore, the most studies showed that therefore, most studies show that adenomyosis can reduce the embryo. Adenomyosis can reduce the embryo implantation and clinical pregnancy rate and increase the abortion rate in IVF. Endometriosis and ectopic pregnancy. A meta-analysis of 15 studies in the February 2002 issue of Journal of Minimally Invasive Gynecology concluded that with endometriosis have a 2.66 higher risk of having ectopic pregnancy compared to women who do not have this disease. Next. Endometriosis and placenta previa. Adverse effect of endometriosis on pregnancy, case control study by the Mao showed that the endometriosis was the independent risk factors for placenta previa after adjustment of the several confounding factors like fertility treatment, pregnancy, pre-pregnancy BMI, etc. Next, the factors responsible for increased incidence of placenta previa may be hyperperistalsis of the uterus, which may be implicated in the abnormal blastocyst implantation. Dense pelvic adhesion may inhibit the migration of the placenta away from the internal os. There is increased incidence in patients with rectovaginal lesion than the patients with peritoneal ovarian lesion. History of surgical treatment before pregnancy and severity of the cases like deep infiltrating endometriosis and stage 4 were significantly associated with the increased risk of placenta previa and subsequent pregnancy. Adenomyosis and preterm labor. A case control study have showed a significant, that is nearly twofold increase in the risk of preterm delivery in women with adenomyosis. The incidence of PROM, which is most important cause of preterm delivery, was higher in comparison with the overall prevalence of the preterm PROM. So the chronic inflammation and high intrauterine pressure in the pregnant women with adenomyosis might be risk factor for preterm PROM and preterm delivery. PIH and fetal growth restriction adenomyosis. Incidence of both PIH and FGR are higher in pregnant women with adenomyosis, as the thickening and disruption of the junctional zone appearance is strongly associated with adenomyosis. The adenomyosis might be related to placental insufficiency and poor placental perfusion, resulting a spectrum of obstetrical complications like miscarriage, late miscarriage, preterm labor, FGR, and PIH. Intrauterine infection in pregnancy and adenomyosis. The functional changes that occur as a result of adenomyosis during pregnancy and after delivery include desidualization and hemorrhage within the adenomyosis. So adenomyosis can be associated with inflammatory consequences like septic abortion, preterm delivery, abscess formation within the adenomyotic foci in the pregnant women. Sometimes hysterectomy might be needed as a result of this severe infection. Endometriosis. Does endometriosis get cured after pregnancy? No, pregnancy does not cure endometriosis. The reality is that pregnancy, like other hormonal drugs, may temporarily suppress the symptom of endometriosis, but does not eradicate the disease itself. Therefore, symptoms usually recur after the birth of the child. Sometimes women can delay the return of symptoms by breastfeeding, provided the breastfeeding is frequent enough and intense enough to suppress the menstrual cycle. The effect of pregnancy, now we must say something about the effect of pregnancy on endometriosis of different organs. The most frequent endometriosis-related pregnancy complications include rupture of the endometrioma, intestinal perforation, spontaneous hemoperitoneum, infection of the endometrioma, developing abscess, and uterine rupture. Impact of endometriosis, pregnancy on endometriosis. It causes the desidualization of the endometriosis. Due to high serum progesterone level, endometriotic lesions are susceptible to desidualize during pregnancy. It is characterized by typical sonography, histological, and the molecular pattern. The change in the size and property of the ovarian endometrium and pregnancy. A study by Bengalia in 2013 showed among 24 women carrying 40 endometriomas, the 46% no cyst could be detected, 13% cyst decreases, 33% unchanged, and 8% cyst increases in size. Among the properties of the endometriosis, in a study by the UDI in 2010 show, the 12% undergo decidualization, 4% have abscess formation, and 4% have rupture of the cyst. The mechanism, what is the mechanism of this? The adhesion due to endometriosis itself or surgery that can cause traction of the surrounding structure leading to rupture. Endometriosis associated chronic infection that may lead to tissue destruction and tissue weakness, so there may be leaking or rupture. Decidualization, edema, vascular remodeling, and angiogenesis. Intra-abdominal bleeding. Spontaneous peritoneal bleeding occur in the second trimester, second half of the pregnancy during labor or occasionally postpartum. And there are some reports of a stillbirth and early neonatal death due to fulminating hemoperitoneum causing hypovolemic shock. In pregnant women with the triad of a history of previous endometriosis, severe abdominal pain, and low hemoglobin level followed by hypovolemic shock, we must consider the intraperitoneal hemorrhage. Next. Bowel perforation. Bowel perforation is thought to be the result of increased traction on the adherent endometriotic lesion by the growing uterus and with intra-intestinal pressure from feces. Next. Spontaneous uterine rupture during pregnancy is very rare in the context of adenomyosis without previous uterine surgery. And there is no clinical evidence that supporting the resection of the adenomyosis will improve the fertility. So, the danger of uterine rupture must be considered in future patient care, especially when surgery has resulted in larger myoma. In the conclusion, we can say the pregnant women with endometriosis or adenomyosis are more likely to present with a wide variety of pregnancy complications, which could result in poor prenatal outcome, require even more careful prenatal management than previously thought. From a clinical perspective, and optimal management strategies for the pregnant women with endometriosis or adenomyosis are required to achieve the better prenatal outcome. Next. Pregnancy has various impact on the women with endometriosis also. Although the incidence is low, but endometriosis-related emergent events during pregnancy would be serious, but can be managed well with knowledge about the impact of the pregnancy on endometriosis. Thank you very much.
Thank you, Madam, for your enlightening speech. We thoroughly enjoyed your talk. We must learn how a very hard topic can be made simple and palatable for everyone. So we would like to know the comments of our chairperson. First, Professor Ifat Ara Madam. Madam, please. Madam Achen. Okay, if Ji, Madam, please.
Am I audible?
Yes, you are audible and visible also.
Okay, okay. Thank you, Professor Tabassum, and thank you, Professor Kohinoor Madam, for your very wonderful presentation. Actually, we all know that endometriosis, it is a very vast subject. This is present even in the intrauterine life, early adolescent, late reproductive age, and it has got also deleterious effect on the pregnancy, because as we have seen from Madam's presentation, that it has every aspect. That is, in the first trimester, it can cause spontaneous abortion. In the mid-trimester, it can cause premature labor. In the last part, it can cause small for gestational age, abnormal placentation, resulting in placenta previa, and even during puerperium, nobody is safe. That is, it can cause PPH, it can cause septicemia, and even in worst cases, it can cause gut perforation. So we should be very, very meticulous in handling the cases during the first trimester, during the second trimester, during the third trimester, and also during puerperium. For example, in any patient presenting with anemia, tenderness, and that is pallor, we should think that some intraperitoneal bleeding is going on. So we must be very meticulous in diagnosis, meticulous in management, and meticulous in thinking, because we gynecologists and obstetricians, we have to rethink, redo, revisit everywhere. Because previously, when we were very early, we used to think that is neonatal bleeding, that is per vagina, was a good omen. We used to say that it's a very good sign. It means everything is okay. But we now know that this good omen is not a good omen. It's a very bad omen. It means that she will likely to develop into endometriosis. So about endometriosis, adenomyosis, we are learning in every step. We are changing our policy. It is a paradigm shift. Previously, we used to think that surgery has a very dramatic effect, but now we are thinking that no, surgery has not a dramatic effect. It is the medical management which is more beneficial, but sometimes surgery is needed to enhance the fertility preserving surgery. So we have to rethink, reshape, revisit, and rearrange all the modalities of treatment. So so in the end, I want to thank the organizers and I want to thank the moderator, because after this, there will be the panel discussion. Thank you.
Thank you, madam. I'm now requesting Professor Ferdowsi Islam, madam, to put her comment as chairperson.
First of all, I thank the organizers, especially Samina Appa, Saleh Appa, and Sharmin Abbasi for inviting me in this session. It is an excellent webinar because I was involved in the yesterday and today also, and it covers everything regarding endometriosis. And I also thank especially to Sharmin Abbasi, who is coordinating very much, and she's in constant touch with everybody. And I listened to my special Professor Kohinoor madam. Special thanks to her because she has covered everything. I think that all the problems and all the underlying mechanisms for those problems, she has elaborated everything. So we all know that endometriosis is a disorder which leads to varieties of pain in women's life. It starts with a dysmenorrhea, then chronic pelvic pain, and ultimately painful conjugal life due to infertility. Nevertheless, still there is a hope. Getting pregnant and having a healthy baby are possible and not uncommon with endometriosis. Maybe the chance is less, 2 to 10% compared to 15-20% for a complete couple without endometriosis. Not only that, having endometriosis may also increase the risk for a serious pregnancy and delivery complications. We have learned all the complications from our madam's lecture. And actually, I don't want to elaborate everything because it is already discussed by Kohinoor madam and Fatala madam. And one study I want to mention that these pregnant women with endometriosis are 1.5 times more likely to develop preterm labor and PROM, and has all the consequences of premature baby. Though it is generally seen that the pregnant women gets better and less pain during pregnancy, but some ladies will find no improvement or symptoms worsen during pregnancy regarding the pain. The reason for this, as the uterus expands to accommodate the growing fetus, which can pull and stretch the misplaced tissue and increase estrogen, can also feed the endometrial growth. So the severity of the endometriosis, hormone production during pregnancy, and the response of the body to pregnancy all will affect the outcome of the pregnancy. So I'm not going to elaborate all the complications that is already discussed elaborately by Kohinoor madam. Even if symptoms do improve during pregnancy, they can resume after delivery of the baby. And breastfeeding may delay the return of the symptoms, but once menstruation starts, symptoms will likely return. So regarding treatment, if the patient has got discomfort, painkillers better to avoid. It's usually the warm baths, some fiber-rich foods, and the prenatal yoga to relieve the back pain, which is more prevalent than the normal pregnancy in case of endometriotic patients. So in conclusion, actually, what I want to emphasize that these patients with endometriosis, when they become pregnant, they need more frequent antenatal care and the intense monitoring because of all these complications. And definitely tender, loving care in the family and also from the healthcare provider like us. Thank you.
Thank you, madam. Thank you. So I'm sharing the slide for panel discussion, right to where we want to go to it. Is my slide showing in the screen?
Yes.
Yes, okay. So we start panel discussion. We do have number of panelists today, dignified panelists, I must say, for the session, who are glorifying the field of obs and gynae by their extraordinary talents. Professor Parul Jahan, she is professor and head of the Department of OB/GYN, Women Medical College and Hospital, Uttara. Professor Afjalunnisa Chaudhary, madam, has recently retired from her government job. Professor Masuda Begum Ranu, she is professor, Department of OB/GYN, Anwar Khan Medical College and Hospital. Professor Akhtarunnisa Parveen, she is professor, Department of OB/GYN, Women Medical College and Hospital, Uttara. And the last but not the least, Professor Nahreen Akhtar, the chairman, Department of Fetal-Maternal Medicine, Bangabandhu Sheikh Mujib Medical University. So let's start with Professor Parul Jahan, madam. Madam, are you there?
Yes, yes.
Okay. Madam,
Yes.
this is about a young patient of 18 years. She is a HSC student, married for 2 years, but doesn't want pregnancy as she is studying. As she has got severe dysmenorrhea and chronic lower abdominal pain, she consulted a gynecologist who noted tender nodules in the posterior fornices and reached to clinical diagnosis of pelvic endometriosis and advised her to go for pregnancy straight away. So what is your opinion about this advice? Should pregnancy be recommended as a treatment option?
Thank you, moderator, Professor Tabassum, for this important question and giving me the opportunity to address this question. Nowadays, this is a very common scenario in our clinical practice, and we are getting quite a good number of patients with young married lady with this pelvic endometriosis and with these symptoms. The index patient, 18 years old, a higher secondary student, married for 2 years, suffering from typical features of pelvic endometriosis, but she does not want to be pregnant at this moment. And she consulted a gynecologist who advised her to be pregnant. But as patient does not want to be pregnant, we could offer her other options for treatment, medical management. The aim of our treatment will be to alleviate her pain, reduce endometriotic lesions, and to improve her quality of life. She could be treated by giving drugs which will suppress her menstruation for prolonged period and also relieve her symptoms. Drugs can be given for this treatment, can be given. These are combined oral contraceptive pill, DNase agonist, DNase analog, danazol, medroxyprogesterone, Depo-Provera. This can be prescribed. However, these drugs are avoided nowadays because of their some adverse effects. Recently, Dynogest has shown a great promise in the management of endometriosis. Its efficacy has been confirmed by large multicentric trials. So it is now best drug at present. Dynogest is an oral progestin, which can be given for a long time, even up to 5 years. And Dr. Mahapatra just told that it can be given even at 6 years also. And we should follow up. When we are giving these drugs for long period, we should follow up the patient at least 3 monthly. Dynogest causes hypoestrogenic and potent progesterogenic state and it is benefit. It causes atrophy of the endometriotic lesions, and it has an added beneficial anti-androgenic property with minimal changes in lipid and carbohydrate profile. It has there is rapid return to ovulation after cessation of the drug. So Dynogest can prescribe her for Dynogest for a long time, at least can be given for 2 to 3 years. We can give her Dynogest. As patient also complains of severe lower abdominal pain, we can also add elagolix. The elagolix is a DNase antagonist, a newer drug which has been approved for endometriotic pain like dysmenorrhea, lower abdominal pain, pain during sex. So we can go for medical management as it is important, but it is important to inform that this patient has endometriosis. So endometriosis is a progressive disease and having some association with fertility. So she should not defer pregnancy for a prolonged period, and she should plan her pregnancy accordingly. Regarding with that next question, should pregnancy is recommended as a treatment. Pregnancy is just now Professor Kohinoor Madam told, the pregnancy cannot cure the disease, but it can suppress the symptoms, and it can, after pregnancy, it may recur again. But pregnancy, during pregnancy, the progesterone will cause. So we can, pregnancy can
be temporarily suppress the symptoms.
Temporarily suppress, yes.
Thank you, Professor Parul Jahan. Actually, should a woman have to bring another woman into the world to relieve the pain of endometriosis is really questionable. But as it has got impact on reproductive performance of a person, thorough counseling about the consequences to the patient is probably key. Probably that is the thing our professor has been told in her panel discussion. Thank you. Now moving to Professor Afzalunnisa Chaudhary. Madam, this is a patient, Naliperas. She presented at 8 weeks of pregnancy. Sorry.
Hello.
Hello.
Hi, I am Professor Afzalunnisa. Am I audible?
Yes, I am giving you the scenario first, madam. Please wait. Are you hearing me?
My laptop disturbed, so I connect with the mobile.
Okay, please listen to the question first. This is about a patient. She is nulliparous, presented at 8 weeks of pregnancy. As she has got lower abdominal pain, she has done an ultrasound, which showed a cystic mass of 7 into 6 millimeter in the left ovary, with highly dense internal echo containing a solid component of size 8 into 7 millimeter. So how to deal with this case, madam? Madam, time allocation is 3 minutes, okay?
Thank you, Professor Tabassum. Assalamu alaikum and good afternoon. I feel honored to be here in this very important international scientific conference. And special thanks to the organizer for having me in this session. In this scenario, 8 weeks pregnancy and 70 into 60 millimeter size cyst and a solid nodule within it. Really, it is a diagnostic challenge for us. So proper evaluation of the patient by taking the history and any previous scan. We also ask for that and examination and further investigation. We know the ovarian cyst is not uncommon in the pregnancy among these dermoid cyst, endometrioma, and its complications, and ovarian cancer also, although it is a rare, only less than 1 to 2%, but this scenario is suspicious for the malignancy. So, and the tumor size is more. So, with additional investigation should be done, that is the Doppler study. It significantly improves the ability to distinguish between the benign and the malignancy. As the vascular flow is high, papillary projection, sometimes you see the nodule. So if the Doppler study is suspicious, then we can do the MRI. It is safe, and now it is the procedure of choice. So all this investigation, also the tumor marker may be done, although we know that during the pregnancy, CA125 is raised. In the endometrioma, CA125 is raised, but it helps for the prognosis of the patient after the management. So
Madam, will you go for surgery in this case?
Yes, we go for the, after counseling the patient, we go for the surgery with the frozen section facility, and as the side tumor is large, with
so
frozen
if
section,
the frozen section, madam, if the frozen section shows decidualized ovarian endometrioma during surgery, what is your comment and what you are going to do then?
Yes, thank you for very nice question. Previously, madam also says the 12% decidualization and some others complications. Madam says so. Yes, decidualized endometrium, though it is a rare phenomenon in the pregnancy, but it still may happen, and which can mimic the ovarian malignancy in imaging and often poses a great challenge. Decidual changes due to the influences of the progesterone, also changes in the ectopic endometrium, especially the ovarian endometrioma. It shows that it may show solid nodule, increased vascularity, sometimes the papillary projection within
Madam,
the...
if there is decidualized ovarian endometrioma on the spot, what you are going to do?
According to the findings, we can do the surgery.
Surgery. You can remove the endometrioma.
Okay, as far as possible, and after counseling before that procedure, we counsel the patient and try to do it in mid trimester. There is a less chance of the miscarriage, although it is rare, but it should be considered as a differential diagnosis of the ovarian cancer. However, large ovarian endometrioma sometimes may rupture at any time. Or it may turn into rare cases, turn into malignancy, or if a small, we follow up the patient. But in
that's why you want to remove the endometrioma.
So my suggestion is, there is a chance of decidualized endometrioma. All gynecologists should be thinking in mind that it is a differential diagnosis, or improve sonographic and all other imaging technique to overcome this problem. So it will help for our daily practice.
Thank you, madam, for elaboration and clear-cut advice. So ovarian endometriosis can have a structural change like decidualization, which may mimic malignancy, that we have to keep in our mind. But surgery is still necessary because we need to exclude malignancy. Thank you, madam, clearing the facts. So now moving to Professor Masuda Begum. This is about a patient of 35 years, para 2+0, both by C-section, last one 1 year back, presented with left-sided lower abdominal pain, which worsens during menstruation. On examination, a knot-like tender structure of about 2.2 centimeter was noted just superior to the left extent of her previous C-section scar. So is this mass need imaging modality for evaluation? Is it a preventable condition, and how you are going to manage? Masuda madam,
okay.
Going to be
so thank you.
Masuda madam, 1 minute just. Our audience are requested to put question in the chat box if time permits at all. Then we'll address the question, and if not, we'll give the question to the respective panelists so that they can communicate with you later. So Masuda madam, your time is 3 minutes, please.
Yes. Okay, no problem. So thank you all for the to give the opportunity to talk something about this matter. So it is most probably a case of clinically a case of scar endometrioma or endometriosis. Clinically, but how we'll confirm this one? This can be confirmed. We can imaging technique by ultrasonograph with Doppler study. By ultrasonography, we will see the exact structure, texture of the thing, and sometimes differential diagnosis like granuloma, any pus collection, anything foreign body, anything can be remain inside it. So endometrial tissue, this is heterogeneity tissue, we can find out here. Somebody doing CT scan, MRI, but it is a very expensive one in our country, and we will not like this. And by Doppler study, the vascular, because endometritic is active endometrium, always high. This is a good blood supply. So by Doppler study, blood flow can see, we can diagnose it. And it is preventable, yes, because it is surgically complicated.
It can excite it.
Yes. Surgically, at a surgical complication can be most of the time it mainly it is happened due to operative surgery. So we can prevent it somehow. Preventively before surgery, we can meticulously select the case. We'll reduce the rate of surgery, invasive procedure, as well as cesarean section, as well as the hysteroscopy, because laparoscopic hysterectomy by morcellation, sometimes we open the endometrial tissue. So we avoid, during procedure also, we'll avoid the implant of endometrial tissue. Clean. This one. And hello.
Please mute yourself. Please mute yourself. It is making disturbance. Please. Okay. Okay.
So make a good mid-surgical judgment is needed for the induction, the indication of surgery first, and during procedure precaution and meticulously. So need only justified patient we can do operation only. So how will manage the case? This is this size. If it is a scar endometrioma, 2.5 into 2 centimeter, very small one. 1 year ago, cesarean done. We'll counsel the patient. We'll manage. This is a case. I'll diagnose it. Endometrial tissue is there. So I'll give painkiller. I can give OCP. Most of the time we can give and delay our procedure. We can by this time shrinkage the tissue. And it is not, if it is increasing, treatment is failure and not, it is progressing because due to the presence of menstruation, mass will be bigger size. And if when continuous menstruation is up, so active tissue going to die smaller in size.
So madam, are you going to excise the mass now?
So lastly, then we can excise. I will patient counsel the patient. We can excise when operative treatment can be done for her. It is the best treatment for her.
Thank you, madam. Thank you, madam. It's uncommon, but we sometimes get this type of things, and it is preventable to take some measures. Wide end block excision with that free clear margin, that is at least 1 centimeter clear margin, is necessary to prevent recurrence.
To prevent the recurrence of the endometrium.
Yes, madam. Thank you. Thank you so much. So next to Professor Akhtarunnisa Parveen. It is about a patient of 38 years. She is nulliparous, trying for pregnancy for 12 years. Her ultrasonogram report showed focal adenomyosis with small endometrioma in right ovary. She was advised for IVF by her fertility specialist. So, madam, do adenomyosis and endometrioma in her will affect the success rate of IVF? And do we need to treat? We want to emphasize to the second part of the question. Do we need to treat it before IVF?
Assalamu alaikum. Good afternoon. Thank you, Professor Tabassum Parveen, and also thanks to organizer to give me this opportunity to tell something in this prestigious webinar. She is 38 years old and having long infertility and adenomyosis with endometriosis. Definitely, she will be benefited by IVF, no doubt, but it is a challenging issue. And there are many studies, and it is established now that adenomyosis and endometriosis both have detrimental effects on IVF outcomes, including higher rates of abortion, lower rates of implantation and clinical pregnancy and live births. And before going to IVF, she will need some treatment to reduce the size of adenomyosis and endometriosis, and she will need injection GnRH analog monthly in each month for 3 months. And it will reduce her adenomyosis and endometriosis, and it will improve the endometrium. Then IVF should be done by long protocol method, oocyte collection, then fertilization and embryo transfer. But if endometrium is not well developed and not suitable for embryo transfer, embryo should be preserved. Again, she will be treated by GnRH analogs monthly for 3 months. She can be treated again to develop good quality endometrium and better endometrium, and also reduce the size of adenomyosis and endometriosis, and it will reduce activities of adenomyosis. And then again, IVF can be done by long protocol, and then transfer of frozen embryo. And I think it will be benefited beneficial for this patient, and it is established now. Because if surgery is done in from our Madam's lecture and from these 2 days webinar, we could learn a lot, and surgery may cause rupture of uterus during pregnancy, and that's why it is not we do not do this surgery, adenomyomectomy, and it will not improve her IVF quality, and so it is better to treat her with GnRH analog, and it will help her. I think before doing IVF, it will improve her fertility, and it will get better result by giving GnRH analog.
So, madam, you are not going for surgery. You are giving
surgery. It is not nowadays. It is not recommended because it will not increase the success rate, and in pregnancy it may rupture, and nowadays surgery is also costly, and GnRH analog, it will reduce. Levonorgestrel still can be given as implant for 3 months. Then IVF can be done, but better to give GnRH analog before IVF.
So long-term GnRH agonist you are prescribing, yes, that is evidence-based. Thank you, madam. Thank you for nice answer. So our last scenario is for Professor Nahreen Akhtar. Madam, it is about a patient of 34 years, para 0+2. She has got 2 miscarriages around 12 to 14 weeks. Her physician advised her to go for thorough workup for RPL, where all investigation appeared normal except adenomyotic changes in the posture wall of the uterus. So my question to you is that, can adenomyosis be the cause for RPL in this case? And if so, does she need any treatment for adenomyosis? Madam, please.
Thank you, Professor Tabassum, for your nice question. Respected all, in this scenario, as all investigation of RPL workup has done and found normal, so it might be due to adenomyotic change in her uterus. Adenomyosis causes implantational failure and also first and second trimester pregnancy loss, as Madam Kohinoor mentioned in her lecture. It is presently unclear whether this reproduction impairment is directly mediated by adenomyosis itself or indirectly caused by adenomyosis associated with known risk factors such as high BMI and advancing age with fetal aneuploidy. Though in some study, researchers found higher chance of pregnancy loss independent of risk factor like age and weight. The causes of implantation failure is due to thickened junctional zone that may impede embryo implantation, and also hyperperistaltic uterine contraction, which make implantation difficult. Now comes what causes pregnancy loss. One is abnormal uterine contraction. Second is changes in uterine environment that can be toxic to embryos. Adenomyosis has been linked with an increase in macrophage and natural killer cell population, plus an increase in the production of inflammatory mediators and reactive oxygen species, all posing potential harm to the implanting embryo. It has also been found increased level of prostaglandin in endometrial epithelium and also altered level of functioning protein, enzyme, and genes in the endometrium. Finally, adenomyosis has been associated with altered endometrial steroid hormone production and receptor expression. Both are key determinants of endometrial functionality. So, adenomyosis causes dysfunctional environment for maintenance of pregnancy, and all this mechanism causes early pregnancy loss. Now come to second half of the question. She had 2 pregnancy loss, so treatment with long long-acting GnRH analog can be tried, which is mostly given, especially in the IVF cycle. We all know adenomyosis is an estrogen-dependent disease. The use of long-acting GnRH analog can control the growth of adenomyosis by inhibiting ovarian function. In addition, in the process of IVF, the pre-treatment with long-acting GnRH analog can not only effectively inhibit LH surge, but can also shrink uterus shape, which is beneficial to pregnancy outcome improvement.
So, madam,
we can
would
give
you suggest GnRH analog in this case before having next pregnancy?
Yes, as she had pregnancy loss, and the different researchers found better outcome if patient receive GnRH analog, and the success rate is good, and this reduces abortion rate. So we can give or try GnRH analog in these cases.
Thank you.
There are other options of treatment, but those patients who need fertility, they can be prescribed with GnRH analog. There are other options of treatment like endometrial ablation, uterine artery embolization, but those patients who want to become pregnant or retain fertility, GnRH analog can be given.
Okay, thank you, madam. Thank you, all the panelists. We are running shortage of time. I am straightway go to the rapporteur to wrap up the session. Thank you all from my side.
It's my great pleasure to thank honorable chairpersons. My special thanks to the speaker for her excellent evidence-based presentation, which will help in our clinical practice. Thanks to the moderator, and a special thanks to the scientific partner for their technical support. Thank you, audience. And now I'm moving to the next session of this conference to Lieutenant Colonel Dr. Sharmin Hussain. Thank you all.
Dr. Sharmin Hussain, you can start now.
Ladies and gentlemen, participants from home and abroad, good day to you all. I am Dr. Sharmin Hussain, welcoming you all to first virtual international scientific session of Endometriosis Adenomyosis Society of Bangladesh, EASB. Our session is plenary session 5. We are honored to have Dr. Khalid Khan from Japan as our chairperson. Dr. Khalid Khan is the ambassador of World Endometriosis Society and Asian Society of Endometriosis and Adenomyosis. He is also international advisor to EASB. We also have Professor Farhana Dewan from Bangladesh as chairperson. Professor Farhana Dewan, she is the president-elect OGSB and organizing secretary EASB. The moderator of this session is Dr. Sharmin Abbasi, scientific secretary EASB. Now over to moderator. Thank you very much.
Thank you. Thank you, Lieutenant Colonel Sharmin Hussain, for your nice introduction to all the chairpersons and also the moderator. Thank you very much. Ladies and gentlemen, it's one of the important sessions of the Conference of Endometriosis Adenomyosis Society of Bangladesh. It's a session of the plenary 5. In this session, we have a very world-renowned speakers among us. We have Professor Luke Rambeus, who is the present president of the World Endometriosis Society, and he will talk on minimal and mild endometriosis pseudoiodine. It is my great pleasure to introduce Professor Luke Rambeus. He is the president of WES, President of the Fertility Society of Australia and New Zealand, Clinical Professor in the Department of OBGYN at Monash University, and Head of the Reproductive Medicine Clinic at Monash Health. Clinical interest, advanced laparoscopic surgery for endometriosis, male and female reproductive microsurgery, and the management of male and female infertility, including all aspects of IVF. We are very much privileged, Professor Luke, to get you among us because you have a very busy schedule and you can manage time and join with us. And he will talk on what we should to do in case of minimal and mild endometriosis. Please welcome Professor Luke, the President of World Endometriosis Society. Sir, please.
Thank you so much. I would like to start by thanking the conference organizers for their very kind invitation. I would also like to mention that I don't have any disclosures to make in relation to any relevant conflicts of interest with this presentation. So in this presentation, I'll talk about minimal and mild endometriosis. And usually they're not considered the most exciting types of endometriosis because I guess everyone feels quite comfortable operating on them. And it's generally assumed that the surgical outcomes are excellent. So why should we then worry about minimal and mild endometriosis? So I think in this lecture, I would like to highlight a few points that I think should make us all consider this a little bit more. The first thing that I would like to raise is classification bias. And what I mean by that is, well, what do we think mild endometriosis represents when we talk about it? Say we were having a face-to-face conversation in Bangladesh and I could join you in the bar afterwards for some drinks and you talk to me about a case that had mild endometriosis. That would conjure in my mind immediately a picture of a pelvis with a few tiny lesions, maybe a few adhesions. And that's what I think mild endometriosis is. But the picture is unfortunately a little bit more complex. If we use the AFS classification, we know that mild endometriosis scores somewhere between 6 and 15. And this slide shows a case where the score is 6. So we can see here there is a little bit of mild superficial disease on the ovary on the right side. She's got a dense adhesion, small one, from the ovary to the left pelvic side wall. And she also got some small adhesions on the left ovary. That's what I intuitively would think about when we talk about mild endometriosis. But this slide is also mild endometriosis. This is scoring 15. Now, this woman has got a small superficial lesion on the pelvic side wall. Yep, that's consistent with mild, but she's also got a 5 centimeter, more than 3 centimeter nodule in the pouch of Douglas. She's got a small endometrioma on the right ovary, and she's got widespread, more than 3 centimeters, superficial disease on the ovary. So they're both mild endometriosis. And it is important that we know that there can be that big range. So perhaps a better way of kind of conversing or talking about minimal and mild disease is to actually map it out. And there's been suggestions that we should always use pictorials like that because it makes it much easier to talk about the same thing, to know what we both mean by mild disease. And if failing that, because it's hard to obviously use pictorials, not everyone is necessarily a good drawer or has access to these maps, at least use the actual AFS score. Because if you talk about an AFS score of 6, we know that that represents something very different than a score of 15. And it's important because when a patient comes to present to us, unfortunately, she doesn't have her score or a classification tattooed on her forehead. So how do we know what endometriosis she has? We don't have X-ray vision to look into her pelvis. Well, symptoms are, of course, one of those things you learn about when you take a good history, and history taking is still very important this day. But unfortunately, it's not a particularly good discriminator to identify stage 1 or stage 2 disease. This is from an American study where they looked at pain typology. And you could see that, women with stage 1 and stage 2 disease would have the typical symptoms you'd expect: chronic pain, cyclical pelvic pain, dyspareunia, dyschezia, dysmenorrhea. But interestingly, even the women with a normal pelvis were frequently complaining of the same symptoms. So Not only does it not discriminate between stage 1 and stage 2, it doesn't even tell you much about whether she's got endometriosis at all. So unfortunately, the supremacy of the surgical diagnosis still reigns. If you want to know whether you've got if a woman has got endometriosis, we probably do need to do a diagnostic laparoscopy, or do we? There is now a strong push to obviously do transvaginal ultrasound, and we know what skills you need to be able to kind of diagnose it more accurately. And that's certainly true for moderate and severe, so the more severe forms of endometriosis. In this study done in 2010, you could see when ultrasound diagnosis was compared with laparoscopy, the ultrasound for moderate disease got it right 20 out of 27 times. For severe was even better, 41 out of 48 cases were diagnosed correctly. Unfortunately, for the more milder forms, the picture is very different. So when the lesions are superficial and they're much smaller, the ultrasound starts to struggle to pick up the disease. So only in 1 out of 33 cases with minimal disease, and only 4 out of 31 was the diagnosis made preoperatively. So ultrasound for the types of endometriosis that we're talking about now isn't going to help us. So unfortunately, if you want a very clear surgical clinical diagnosis, you'll have to do a laparoscopy. So we talked a bit about diagnosis and the issues there, but what about surgical interventions, actual performing surgery for stage 1 and 2 endometriosis related infertility? Now, the best study that was ever done, the best RCT, was still the EndoCan study. That was a Canadian study done by Marcoux. And you can see here in a systematic review, it's still the largest one. And the systematic review does say that if you do excision or ablation of minimal or mild endometriosis, there is a clinical benefit. It's statistically significant effect. If you work it out in terms of numbers needed to treat, so how many laparoscopies with excision and ablation do you need to do? You need to do about 8 to 9 for 1 extra pregnancy. Now, of course, not all women with infertility you will do a laparoscopy on will have endometriosis. So if you assume you might need to do, there's about 1 in 3 infertile women with stage 1 or stage 3, then you will actually need to do 25 laparoscopies to get 1 extra clinical pregnancy. And for that woman who's got the extra pregnancy, she'll obviously thank you on both her knees, but the problem is that still a cost-effective treatment? 25 laparoscopies is, a big cost to society, it's a big cost to the patient, it's certainly also an invasive intervention. Another way to look at the Marcoux study is one of the graphs they had in their original report, and you could quite clearly see that laparoscopic surgery provides a higher cumulative pregnancy over time. They looked for 36 weeks after randomization. There's no question that intervention was better than just looking. However, if you look at the benefit of laparoscopic surgery and compare it to the cumulative pregnancy rates expected in fertile women, the natural conception rate is much higher. So surgery improves things, but doesn't bring it back to normal. And if you compare to IVF expected cumulative pregnancy rates, this is drawn from our Australian data, you could see that laparoscopic surgery still lags behind. And I don't want to get into the discussion whether one is better than the other or more cost effective. That really is a discussion that varies so much from country to country, depending on your rebates and the reimbursements by government. It's a hard discussion to have, but clearly just based on outcomes, IVF beats laparoscopic surgery hands down. So what about surgery for pain in women with stage 1 and stage 2 disease? Now, there's lots of evidence, and I can't obviously in the 20 minutes talk about all of it, but I wanted to show you 2 studies from my colleague and friend, Jason Abbott in Sydney. This is a prospective study he did back in the early 2000s, where he looked at a large cohort of about 250 women, about 135 of which had surgery and complete follow-up for 2 to 5 years. So that was a big undertaking, contacting them again after 5 years, making them fill out questionnaires. Now, the salient points I want to make, and keep in mind, this is for the whole cohort, stage 1 to stage 4, is that 33% of these women had symptoms that had gotten worse in 25 or remained the same in the remaining 8%. In 62%, analgesia and or hormones were required post-op to reduce the symptoms, and a full 33%, 1 in 3 women, did require repeat surgery, 40% of which actually didn't have recurrence of the disease. So I think they're important things to keep in mind when we talk about efficacy and the outcomes of surgery. Now, the follow-up trial that he did was a randomized placebo-controlled trial. I don't think we'll ever do another placebo-controlled surgical trial like this again. It was a smallish study, but it revealed some interesting things. So women were randomized to either a purely diagnostic approach or an interventional approach, and they weren't told whether they were in either one of the groups to make sure that they weren't biased by what surgery actually had occurred. Now, what I want you to focus on, because we were able to extract the data for stage 1 and stage 2 from this study, is the 2 lines at the bottom in red. So when you compare the RFS scores before the first and the second surgery a year later in the diagnostic group only. So I remind you, these were women with stage 1, stage 2 disease. They went in, had a look, took pictures and did nothing else. And they went to have another look a year later. 55% of these women showed no progression, with 6 out of 18, so 33%, where the disease was unchanged, and in 1 in 5, there was actually spontaneous regression of their lesions. So we know if you leave the disease alone, in actual fact, in 50%, nothing bad will happen. In actual fact, in some proportion, significant proportion, the lesions will actually improve on their own. The second point I want to make from this study, this is now again looking at all stages, is that in the diagnostic group only, 32% of these women had improvement of their pain. That's effectively the effect size of the placebo group. So in 32%, they reported, even though nothing was done other than a look, that they actually had better pain management. And in the interventional group, there's no question, there was improvement of pain. It was the main outcome of his study. There was improvement with interventional surgery, but in 20% of the women who had the intervention, there was actually no change or worsening pain after the intervention. So the idea that we can help all women with surgical intervention is certainly a fallacy. What about that vexed issue of surgically treating women with asymptomatic stage 2 disease? So assume you're doing a tubal ligation, you're doing a laparoscopy, she's asymptomatic, she's there because she doesn't want any more kids, and you find stage 2 disease. Should you remove the lesions because you're in there anyway, if you have the time, or should you just leave it alone? For the reason we mentioned before, there's a reasonable chance that these lesions might even disappear by themselves. But what if the symptoms would actually get worse? Is there evidence that on average, there is progression of that disease and you're better off to take the disease out? Well, we have a Canadian study that actually looked at that. So there was a significant cohort of women who had a tubal ligation at some time when they were asymptomatic. And they were asked 10 years later, 10-year follow-up, what the symptoms were. And so those women who were diagnosed with asymptomatic endometriosis, you see 10 years later, they present with dysmenorrhea, premenstrual pain, dyspareunia, pelvic pain, not entirely unexpected. The disease has caused issues. But the interesting part of the study was that those women who were asymptomatic at tubal ligation and did not have endometriosis, 10 years later, they complain of exactly the same symptoms. In actual fact, the only significant finding was that these women with no endometriosis were more likely to have pelvic pain than the ones who were presenting with asymptomatic endometriosis. So again, an argument perhaps to not rush to surgery in those milder forms. And this is reflected in the ESHRE guideline, which, as you know, have now been updated, and it recommends that clinicians should not routinely perform surgical excisional ablation for an incidental finding of asymptomatic endometriosis, because the natural course of the disease is not clear. And then there's the argument, well, look, I mean, I do want to give my patient a surgical diagnosis. She's got the right to know whether that's what bothers her. So I'm going to do a surgery, I'm going to do a diagnostic laparoscopy. And if there is disease, then I'll be in a position to actually remove it. And the reason I'm doing it is because there is a positive benefit risk ratio. The risk is quite small and the benefit is certainly there. That is perhaps exuberant optimism. All surgery has a risk of complications, sure. If the disease is minimal or mild, that is a lesser risk. And from this study, for minor laparoscopic procedures, we know that the risk rate varies between 0.6% and about 7%. So say it's low single-digit numbers. If it's 2 in 100, that's still 1 in 50 women. And the problem is that it is not related to your surgical skill or the severity of the disease, because 1 in 3 to 1 in 2 of all complications occur during entry of instruments. That is site hernias, gas embolism, deep vein thrombosis, anaphylactic reactions with anesthetic complications, positional nerve damage. It doesn't matter how good a surgeon you are, these are the risks every patient who undergoes surgery is exposed to. And this is another interesting study that relates to surgical risk. This is a really good study you should have a look at from the group of Sun Wei Guo in China. This is obviously in mice. It's an experimental study where he introduced experimentally endometriosis in recipient mice. And then you had 3 groups of mice: control group, a group of mice that underwent a mastectomy, and then a group of mice that underwent intra-abdominal surgery. And what they wanted to know was whether the surgery had an impact on the size of the lesions. And they actually took the lesions out after surgery and weighed the lesions to see progression of the disease. And what you can see is that compared to the control group in both surgical groups, but it was worse in the intra-abdominal surgery group, that the lesion size increases. So surgery appears to, in itself, make the progression quicken in the case of endometriosis. And what he also showed quite elegantly in his study is that this is probably related to surgically induced stress, which we know is mediated by the adrenergic pathway. And when he used propranolol to block that effect, you could see that the lesions did indeed not grow. And you could argue, of course, that may be true in an experimental mouse model. How relevant is that in the clinical situation? Well, to his credit, he asked his PhD student to try and find out whether there was any evidence that that would also apply in humans. And he looked at 212 women with ovarian dermoid, and these were the controls. He had 208 cases, which were women with an ovarian endometrioma. And when he compared both, he could see that the women with the endometrioma were 4 times more likely to previously have had open abdominal surgery, but 2 times more likely to have previously had cesarean section. So there's strong evidence that this effect also, the effect of surgical stress on the risk of developing more advanced endometriosis, also applies in a clinical setting. So let's retrace our steps. Surgery, we've shown, is not without risk. And certainly we've now shown with the experimental model that repeat surgery can further compound the disease. Surgery is, sure, it's effective in stage 2 disease when you treat women for pain or for infertility, but you should not overestimate the impact that it has. And surgery does not really yield an accurate diagnosis. We know there's issues with histology not confirming the visual diagnosis. It's perhaps not even a useful classification. We know that the AFS classification doesn't correlate well with pain. So why do a laparoscopy to begin with? And I would like to point out this article written by 3 past presidents of the World Endometriosis Society and 1 past World Congress of Endometriosis president. And they state in their article that non-surgical diagnosis based on symptoms, physical findings, and transvaginal ultrasound alone is possible in most women with symptomatic endometriosis. And except in doubtful cases, laparoscopy should be intended for surgical treatment only, not for diagnostic purpose. In other words, early diagnosis and diagnostic laparoscopy are not synonymous. And I couldn't agree more. And to quote William Osler, one of his famous quotes, care more particularly for the individual patient than for the special features of her disease. And that's why so nicely, if I can put it that way, the nice guidelines in the UK have said that for the staging, you should not be concerned too much with the stage of the disease. You should offer endometriosis treatment according to the woman's symptoms, her preferences and her priorities in life, rather than the stage of the disease. So that brings me to empirical treatment of symptoms. Perhaps a diagnostic surgical test is too invasive and perhaps too expensive, depends on your medical healthcare system. Is it really essential or perhaps even beneficial to know the diagnosis, a surgical diagnosis, or can we work with a presumptive diagnosis? And would a surgical diagnosis really change the actual management? We know that there is good evidence for empirical treatment. Most learned societies like ASRM, ESHRE, WES endorse the use of progestins, extended cycle oral contraceptive pills, non-steroidal inflammatory drugs, and GnRH analogs for the initial treatment and perhaps sometimes also for the tentative diagnosis of women with suspected endometriosis. Sure, if the patient has severe, persistent, or recurrent symptoms, if she's got signs of deep endometriosis either on examination or ultrasound, or if the initial empirical treatment is not effective or is not well tolerated or contraindicated, you should refer. And ideally, you should refer to the appropriate expert with endometriosis skills. So to round it off, I'd like you to show you this last slide. This is a quote that Confucius might have said. He didn't say, but he might have. A good surgeon knows how to operate. A better surgeon knows when to operate. And the best surgeon knows when not to operate. And with that, I'd like to send you a kind invitation to the World Congress of Endometriosis in 2023 in Edinburgh. I hope by then we'll all be sitting in a hall together, shaking hands, greeting each other, having drinks in the bar afterwards. And as you know, the best source to update your knowledge on endometriosis is the World Endometriosis Society. Thank you so much.
Thank you. Thank you very much, Professor Luke, for your excellent presentation, sir. And it's really a mind-blowing presentation. And you perfectly judged the topic of your presentation because the gynecologists, the fertility specialists all have the debate regarding what to do and what not to do with the mild and the moderate endometriosis. I think your presentation is completely a guideline for us that in future, when we are dealing this sort of the patient, then what should be keep in our mind. And there are lots of questions in my hand to you, sir, but I will take it if the time is permits after the second presentation of today's session. Thank you again, Professor Luke, the President of the World Endometriosis Society, for your excellent presence. And it is also enriched our society also. Thank you very much, sir. I'm now requesting our second presenter. Our second presenter, also a legend in the era of endometriosis and the uterine disorder. He is none. He is Professor Felice Petroglia. He is the president of the Society of Endometriosis and Uterine Disorder, founding member of SEUD, member of the board and committee of FIGO, ISGA, ESHRE, and EBCOG, and served as consultant of Ministry of Health and Ministry of University of Italy. Recipient of award from the Endocrine Society, SGI, SIGO, SIE, and Academy of Lindsay. And sir has a many academic activity and also the research work on endometriosis and uterine disorder. And he will talk on a very important topic, that is the setting the realistic expectation, because when we are dealing with endometriosis patient, expectation from the patient has, and also expectation from the physician side also. So please welcome Professor Felice Petroglia, will talk on setting realistic expectations in the treatment of endometriosis. Please welcome, sir.
Good morning, Dr. Sharmin Abbasi, and thanks for all the organization of this event, because you were very close to us in the correspondence. I will start from this This is my first slide, sorry. Okay. This is the University of Florence. This is the disclosure. So it's a common question in the management of, and also now Professor Luc Rombout discussed what's the best to do when we have a patient, what to do, surgery or medical treatment. This is the expectation. Many women come and say, oh, I would like to remove my disorder, and depending on many factors. So the decision before was considered because we had very few medical treatments. Now we have much more, so we can have more option as doctors. What is my presentation today? I would like to discuss with you which are the factors influencing the treatment decision, because it's very important, as now discussed by Luke, that depending on the localization, for example, if we have a superficial, if we have an endometrioma, or if we have a deep infiltrating endometriosis. So we have to judge according to the phenotype of endometriosis. Secondly, we have to judge according to the concomitant disorders. If you realize in your experience, many women with endometriosis, these are 4 publications in the last 5 years, because literature in this field is coming very fast. We have to move in the last decade. We cannot go back to the last century. And we have to move on and say, okay, we have patients with endometriosis, but 25% they have also adenomyosis, 39%, 33%, 47% have also adenomyosis. So when you have to consider this surgery or medical, you have to think, oh, if I remove the endometriosis, I still keep adenomyosis inside. So what is the beneficial for this patient? And sometimes you have also fibroids. This is even more complicated, not easy to decide when you have a patient with endometriosis, adenomyosis, and some fibroids. So very important for gynecologists. The second issue is comorbidities. Our patients are not free, simple endometriosis, infertility, or pain. They have also stress-related disorders, migraine, depression, anxiety, chronic fatigue, sometimes systemic comorbidities, hypothyroidism, fibromyalgia, rheumatoid arthritis, lupus, or inflammatory bowel disease, appendicitis, interstitial cystitis, cardiovascular disorder. So when you have a patient with endometriosis and sometimes with adenomyosis, and also she has hypothyroidism, you have to decide very carefully and share with her what is the outcome, because probably you forget to treat the hypothyroidism, or you forget to treat the inflammatory bowel disease, which has an impact on quality of life and infertility too. So these are many publications now, again 2020, very recent one. There are women with inflammatory bowel disease. So we have a better understand the association between endometriosis and all these comorbidities. This is absolutely very important. Third point to consider. This is also was discussed by Luke before, recurrences. Women who are operated or are under medical treatment, independently from which one is the treatment you decide, may have recurrences. There are some publications. This is a very recent one, again, by Tommaso Falcone in USA. He published in 2018 a publication on relapse of pain after surgery, and he's a Mayo Clinic is one of the most famous American surgeons. Absence of improvement of infertility, revisualization of lesion with imaging or surgery. So it's very scary for patients to know that you can have a relapse. And if you read the publication by Sun Wei Guo, as mentioned before, overall recurrence between 22% with 2 years, 50% within 5 years. So in our consultation, in our counseling with our patients, we have to say, please be careful with the surgical treatment. We have to remove the lesions, absolutely, but repeated surgery must be avoided. This is something absolutely we should try to be careful and to decide when is the best time for surgery. Surgery is very important for endometriosis, but depending on when we have to do. Because if you see here, this is from UK, British Journal OBGYN, and again, women with endometriosis have a high risk of multiple surgery. Odds ratio is 1.69. We published this on low quality of life in patients with recurrence and reoperation. You see here, the yellow one, recurrence and reoperation, very low physical and mental score. So this is a very impact. And this is another publication we did very recently. Women who have a better prognostic life for quality of life, the one who were firstly operated at older age. If you are operated when you are 20, it's much worse. If you are operated at 30, 35, you have a better, and single surgical intervention, you have a better quality of life, less symptoms and lesion recurrency. Of course, these are a large-scale study in which we define that to postpone the operation to do one surgery is absolutely the best option we may offer to our patients. And then I come to the up-to-date today on which one are the medical and surgical treatment, the best we have. And this is a discussion in many meetings. Also, your society, of course, is debating today. The World Endometriosis will do in 2023, but it's every month, at least, we have discussion on which one are the best. As mentioned before, many societies now agree on empirical medical treatment for painful symptoms should be considered either prior to or without laparoscopy confirmation. Was discussed before by Professor Romboz, and I confirm the same project. What is changing in the field of medical treatments? We have just recently going to publish on Review Endocrine Metabolism Disorders that the world is increasing in number of drugs. We have many more drugs than in 25 years ago. That's why all the studies should be done after 2010, when we have new drugs to compare with. Because if we compare with old drugs, with old treatment, it's old enough now. These are very old drugs. We still use GnRH analogs or MPA, but very low. But now we have Dianogest, we have a good progestin, and then we have the new antagonist, which will come on the market very soon. Relugolix, Elagolix, which is already marketed in US, and Linzagolix will come later. What are the mechanisms of action? You see here, GnRH antagonists, they work on inhibition of pituitary, LH and FSH secretion, as well as progestin. However, progestin and combined oral contraceptive work on anovulation, on amenorrhea, directly on the uterus, and there is also a direct effect on endometriotic implants. This is a recent, again, publication we did on HRU and Review. And these are, so we have one mechanism of action here, three mechanisms of action for those progestin. And these are becoming very popular. Our colleague Bob Casper published a few years ago that probably progestin all pill may be better than combined estrogen progestin pill because they are much more straightforward to the mechanism of action without estrogen. Estrogen is a pro-endometriotic drug, hormone. Why to use? So we can use progestin on pill. And also ESHRE and the Society of Obstetricians and Gynecologists in Canada, the first choice should be lower cost, the progestins can be considered the first choice. Dianogest is effective long-term treatment option for endometriosis. This is clear after 2010. And what are the mechanisms of action of Dianogest and progestin in general? All the progestin work on inhibiting HPO axis classically, but they also restore progesterone sensitivity, decrease prostaglandin, COX, the inflammatory metabolism. They increase apoptosis, reduce cell proliferation, decrease vascular and nerve growth factors. So they can improve symptomatology of those women with endometriosis. And also the modern management for an endometrioma, depending on the age, if she wants or not a baby. Of course, if she wants a baby, we can have another decision, but if there is no desire of pregnancy, there are only pain symptoms, there is a clear imaging feature without no doubt of cancer, you can have absolutely Dianogest, for example, because you can change the volume. You see here, these 3 publications, very recent, they all demonstrate a reduction of size, reduction of pain in women with endometriosis with 2 milligram Dianogest per day. And this is a patient we had when she was 18 years old. She had a vaginal ultrasound, ovarian cyst of 6 centimeters, very clear. However, the surgeon removed the ovary because probably was in a general surgeon. And at 20, so 4 years later, she had a HOMA recurrence in the remaining ovary with 3 centimeter cyst. So what to do in this patient? This is a very common situation sometimes because really general surgeon remove very quickly the ovary and you have only one and you have another recurrence. So it's really very difficult to say, do another surgery here. It's almost unethical. So we have to what to do after we have operated. There are publications now on JPPD, on European Journal, Reproductive Science, Journal of Obstetrics and Gynecology. They all demonstrate the endometrioma recurrence. If you use Dianogest for 60 months, you have only 4% recurrence. 69 versus 4. It's impressive difference. So and all these publications demonstrate the early recurrence of post-surgical reduced the risk of repeated surgery. So Dianogest has been shown in many Asia. These are Japanese studies, or as well as in European studies, that we can control our patient after removal of endometrioma. Before and after, we have to treat these patients. However, we have to judge, as of course, AMH, ovarian reserve, and offer fertility preservation. This is very important. In our patient, 22 years old, we should offer absolutely fertility preservation before to do any medical or surgical treatment. What about deep infiltrating endometriosis? This is very critical, very painful. We would like to remove immediately. However, some of our patients, they do not like it. So we can try first to use the Dianogest for 2 years. This is Arada from Japan, relief of symptoms, reduction of sites. Dianogest for long-term treatment is effective. You see here, 5 years treatment. We reduces pain in post-surgical. So this is really in the volume, reducing the volume and nodules also. This is really important. And this is the Asian study, the ENVISION, in which Dianogest therapy demonstrate to be effective in improving quality of life and pain. So 78% of women had a really good response to this large study in Asia. This is a very recent minimal invasive journal, Gynecology, 2020. Dianogest risk of recurrence following surgery. And you see here, absolutely, patient receiving Dianogest after conservative surgery had a lower risk significantly of postoperative recurrence than those who were expectantly managed. So really, we have to be, as gynecologists, to learn when to use surgery, when to use medical treatment, when to use both, because really we can have a, and this is a very recent study we published on RBMO, and you see here, if you have a hormonal treatment, both before and after first surgery, you have much less recurrence than you have only hormonal treatment after the first surgery here. And if you have no hormonal treatment, absolutely the recurrence is absolutely much faster. So the future, probably we have to treat our patient for a certain period of time, then removing the endometriotic lesion for desire of fertility or whatever, or because the drug is not working, and then we have to go back to medical treatment. The analogs, as I mentioned, are very useful, in particular in medical assisted reproduction. Women, this is a recommendation B from ESHRE, but absolutely there are evidence now that if you use GnRH analogs before IVF, you may improve. Also because sometimes you have adenomyosis. That's why probably it's very fruitful. The antagonist will be the future, blocking the ovarian estrogen synthesis with various levels of hyperestrogenism, or probably also because they some of these compounds will be associated with an add-back treatment. So elagolix is only antagonist, but relugolix and linzagolix will come with an add-back therapy in combination. So in the same pill, oral pill, we will have the blockade of hypothalamus pituitary ovarian axis. Finally, what is the future? Because many companies now are working hormonal drugs and non-hormonal drugs. You see here antagonists and the analogs, the oral contraceptives, but there are companies working on aromatase inhibitors, on SERBs, on progestin and SPRMs. These are the future drugs. On inflammation, I am aware of prostaglandin receptor antagonists and monoclonal antibodies. We did some in vitro, in vivo studies in animals. And then other possible drugs working on proliferation, stress, neoangiogenesis, and neurogenesis. So as a gynecologist working on endometriosis, we have to learn how to do the diagnosis first, how to treat our patients, how to counsel them with a medical or surgical treatment, and what are the new drugs for the future, because it's really, and as I mentioned also, what are the comorbidities in our patients. So in this list you see here, we started from non-invasive diagnosis, comorbidities, recurrence in medical surgical treatment. Our proposal, the most view is not in general, is a long life approach. You see here, in the past we had surgery, histological diagnosis for endometriosis, multiple surgery, poor or short use of medical treatment, goal to achieve pregnancy. Only gynecological perspective. Now we have to have imaging, more empirical medical treatment, the surgery well scheduled, and when desired pregnancy, and multidisciplinary approach of endometriotic treatment. So this is absolutely, the world is changing in the new century, absolutely new studies. We have to work on this new publication and do our meta-analysis and evaluation before to draw any conclusion. That's why this is my team in Florence with the radiologists, psychiatric, psychologists, and gynecologists. And then we start to meet in hybrid. This will be an hybrid meeting, because many people will come to Stockholm, but also we will be online. And in Copenhagen, we will discuss how dispelling myths and removing stigma from endometriosis and uterine disorder. So you are welcome to join us as the annual meeting of SEUD. Thank you for the attention.
Thank you, Professor Felici, for your excellent presentation. And you perfectly judge one thing, sir, in your one sentence, that we need to rethink regarding the management of endometriosis. You told us about the medical management, surgical management, or both we may need to treating this sort of the management. And you perfectly give the comparison between the past aspects of the management of endometriosis and the modern stage or steps of management. Thank you again, sir, for joining with us, and thank you very much. I have many questions in my hand, but before going that, I just want to take some remark from our chairpersons. First of all, I'm requesting Professor Farhana Dewan. Professor Farhana Dewan is the president-elect of our National Society of Obstetrics and Gynecology, OGSB. Professor Farhana Dewan, would you please put your comments or remarks regarding the presentation of both of these legendary speakers of the world? What is your opinion, madam?
Thank you so much, Dr. Sharmin Abbasi. First of all, I'd like to express my gratitude to be here as a chairperson in this very esteemed platform with so many esteemed and so many learned, enlightened presenters, and of course my co-chair, my chairperson as well. I think I have been very much enlightened with these two presentations. I would like to comment on Professor Luke's presentation that SAR has started with the classification bias. He has discussed about the mild cases because not always detect the early cases, mild cases, which is very important. Then SAR went on to the surgical aspects for stage 1 and 2 disease, for infertility, for pain, and for asymptomatic cases. And we have found how there are fallacies in each and every step, and how we need to keep ourselves updated and keep our eyes and ears very much alert that there may be a cause which it may be advanced dimension, that we should be alert, and we should know, of course, we should worry when there is a mild case, because even in asymptomatic cases, we can have advanced surgery. And like surgery management for infertility cases also, we have found the same thing, and also regarding the pain management. So this is very important in Sir Luke's presentation. And last of all, he has mentioned that a good surgeon knows how to operate, and better surgeon knows when to operate, but the best surgeon knows when not to operate. With these few words, I would conclude his presentation. And regarding Professor Felix's presentation, I think that we have also known that at what point to do surgery, at what point to do for medical management, at what point to do for both. And we have found in Felix sir's presentation, he has just shown the evolution of the medical management, where we began in 1975 with danazol, and now we are landing up with elagolix and ligazolix in different countries. And I think that it is very important, and Sir has also mentioned about the recurrence, and he has shown in his presentation how we can go for hormonal treatment first, go for surgery, again there might be need to go for hormone. We know that also. I think at the bottom line, I would just like to, yes, another thing regarding the use of Dynogest, we have learned today in other presentations also the long-term use of Dynogest. That is, for long-term, he has given for Dynogest and recurrence of OME, he has said for 60 months, and for deep infiltrating for 5 years. I think these are the take-home messages we can take from these two presentations: how long to give, when to give, and how long to give and when to know that the woman is cured. Thank you so much for giving me the opportunity to chair this session. Thank you, Professor Samina Chaudhary, Professor Saleh Begum Chaudhary, and of course, Dr. Sharmin.
Thank you. Thank you, Professor Farnadan, the president-elect of our national committee. Now I'm requesting Professor Khalid Khan, sir. Sir is the international advisor of the Endometriosis and Adenomyosis Society of Bangladesh, and he is the person who always encouraging us to do the good works on this field. And also, sir stimulated us to form an endometriosis society in our country. We formed the society, sir, with your guidance, and after that we organized this sort of international scientific conference. I don't know, we can make you happy, but we try to make this webinar and this conference in a standard of international. So may I request Professor Khalid Khan, sir, to put your important remarks regarding the presentations of two legendary speakers. Sir, please.
Okay, thank you, Sharmin, for your very nice comments. I'm just trying to do something better for other countries. So that is my purpose and policy, especially who are suffering from endometriosis. So it is my great pleasure to chair this session with two outstanding speakers. Hi, Felice and Luke, how are you? It's very good to see you after a long time. And first of all, I want to appreciate for your great contribution to the EASB. And I'm sure that from your two outstanding topics, they can learn something new and updated information. So I just want to say some comments on our first speaker, Professor Luke. The content of Professor Luke's talk is that if there is asymptomatic, that means either minimal or mild endometriosis, we don't need surgery. But if it is symptomatic, we should be very careful to do the surgery. And in addition to that, Professor Luke mentioned that if we do surgery, unnecessary surgery for either asymptomatic endometriosis, that means early stage endometriosis, it may cause some added side effect. So as a clinician, we should be very careful whether we should do the surgery or not to do the surgery, or we should start the medical treatment from the very beginning. But I think when you think about the stage 1, 2 endometriosis, I think the stage is not the very important factor. The factor is the activity of the lesion. As you know that we have 3 types of lesions: red lesions, black lesions, and white lesions. And we published several papers in 2010 to 2014 that even it is a stage 1 and there is a single red lesion, the inflammatory reaction in the pelvis is very strong, and inflammatory reaction in endometrium is also very strong. So it may cause the symptoms. So we should be very careful. So when we look at the stage, early stage endometriosis, we should be careful to take care of the activity of the disease, whether it is red lesions, black lesions, or the white lesions, and then we should decide whether we should remove it or we don't need to remove it, and we should follow up the cases for the sequential increase of the symptoms. And the second talk, Professor Felice Petraglia, in the last part of his talk, he mentioned about the modern and the medical management, hormonal management. I think we already know about all these treatment options, about the recent hormonal medical treatment. What is the point from his talk? That the point is, when we take care of the endometriosis, we should be very careful. Coexistent disease, like Professor Phillips mentioned, that in endometriosis cases are coexistent, 20 to 40% of adenomyosis, and about 30 to 50% cases, these women are coexistent with uterine myoma. That means if we just do the surgery for the cyst, for the ovarian endometrioma, and if we neglect the coexisting disease, I think there is no resolution of the symptoms or the disease. For that reason, what is most important that we have an in-depth knowledge on this field. That's why 20 to 30 years before, it was considered that endometriosis is an estrogen-dependent local condition. But now, in this modern era, the concept is changed. We have to think about that endometriosis is not a local condition. We should consider endometriosis as a multifactorial and the systemic disease. As the Professor Felice Petraglia mentioned, that we have to be careful also about the systemic manifestations and other disease. Otherwise, if we ignore all those coexistent and systemic disease, I think it is very difficult to improve the quality of life of these women who are suffering from endometriosis. So our focus of knowledge and our focus of treatment should be very broadened. Then we can correctly treat these patients with endometriosis for the true improvement of the quality of life. Exactly. And we also should not ignore the early endometriosis, stage 1, 3 endometriosis, because as a Professor Luke mentioned, that the good surgeon is that surgeon who always think about the surgery, not for the side effects. So in fact, the cases with ovarian endometriosis, they had 70 to 80% of coexistent stage 1, 2 disease. So just cystectomy is no use. We need to take special care to remove the coexistent, very active lesions although it is very important to completely resolve the symptoms, it is very important to resolve the true improvement of the quality of life. So finally, I want to thank the Professor Luke Rumbers and also Professor Felice Petraglia for your excellent talk. And I'm sure that all the doctors of Bangladesh, they got some good essence from your talk. And thank you again for your great contribution to EASB. Thank you so much.
Thank you. Thank you, Professor Khalid Khan. And I have some time in my hand because after this session, we have the lunch time. So 1 hour is our break time. So I can take some important questions from the chat box and also from our trainee. My first question to Professor Luke, sir. Some of our students ask that sometimes we get some symptoms like mild or moderate endometriosis in case of adolescent girl. For the management of the adolescent age group, which investigation is perfect for them, because they're the unmarried girl and the transvaginal sonography is not allowed for them. So in which investigations you prefer for them, and what should be our strategy of the management? And additionally, one question added, another person here is, when we are dealing with adolescent endometriosis, sometimes if we need surgery, so to see the ovarian reserve is important for them or not. So 2 questions I am adding for you. You should proceed, sir.
Can you hear me? I've turned on my microphone. You can hear me all right? Okay.
Yeah.
Look, I think in general that the main goal for all doctors should be to listen carefully to your patients, as I said before, to find out what their goals and aspirations are. I think we far too quickly, because we're so busy, we've got little time, we look for certain points in their history. We see, all right, she's mentioned period pain, she's mentioned this, she's mentioned that, it's endo, until proven otherwise, I'm going to put it on the list for laparoscopy. And yeah, I mean, it pays for our holidays and things like that. But I think, unfortunately, that's not necessarily always in the best interest of the patient. And I think that general principle doesn't change whether the patient's young, very young, adolescent or older. I think you need to first listen. What is it that she is suffering from? What are the main symptoms? What does she want you to do about it? And for some patients, it will be surgery. For some patients, it will not be surgery. In terms of what imaging techniques, because of course, symptoms, as I showed you, are not particularly good distinguishers. I think there was one study that showed if dyschezia is a main factor, so severe dyschezia is usually a fairly good sign, more than dyspareunia, of deep endometriosis. But now we're no longer talking about stage 1, stage 2 disease. But in the adolescent girl, I'd say clearly some women will be happy to do, or young girls will be happy to have a vaginal ultrasound. But if not, then we are fortunate enough that we can send them to a good site here where they do MRI. So MRI in the right hands. Again, it's not the machine that matters, it's the radiologist interpreting the images. So an MRI is a good preoperative alternative, especially in those cases where you think it might be more severe disease. But if you're young, you think the symptoms are not consistent with severe disease, presumptive diagnosis with empirical treatment is what you should do first.
Okay, sir. And another question that was added with it, sir, do you see the ovarian reserve when we absolutely have the indication to the surgery for the adolescent girl? So is there any importance to seeing the AMH level for this kind of patients?
Well, I could have a half a day talking about AMH. I mean, I think in general, yes. If you had a woman, a young girl with an endometrioma, I think you should always do one before you contemplate doing endometriotic surgery, so on the ovary. But in a woman with, if we're talking about stage 1, stage 2 disease with symptoms that are bothersome, I don't expect to find that the AMH will be particularly useful. I think if you're not planning on taking out any ovarian tissue, if it's available, if it's rebated, it might be a good baseline to know what her levels were at a young age. But I don't think that would help me much in the planning for her medical management. But look, I accept that that may not be a common view.
Thank you. Thank you, sir. Now I'm going to Professor Felice because you have the business, sir. You have another meeting. Just two questions for you, sir. One of our Dr. Rashim Shahaks to you, sir. When a young adolescent girl have a chocolate cyst, right, 8 or 9 centimeter, in that case, Dynogist is working better in here, or surgery, or rethink before doing surgery. So what should be our plan?
This is a very common question to all the meetings we have all over the world, because we have a Gaussian curve in our practice. This is the last 10% of the curve, because it's not very common to have a 10 centimeter cyst. This is absolutely uncommon. So of course, in this situation, the drug will be difficult to be effective. However, we have to reflect before to do the surgery. It's difficult to propose a drug when you have a 10 centimeter cyst. However, as Professor Khan said, we have to think about that more than the cyst could be then another deep lesion. Very recently, there is a publication. Then when you have a cyst, you may have a deep infiltrating. So you remove a cyst very simply, and then you leave the deep there. It's very complex.
Professor Luke want to add in here. Yes.
Yeah, I wanted to just ask Felice whether perhaps there is a role, as Jacques Donnet has referred to in the past. Maybe it's not a clear distinction between excision or ablation or medical treatment. Maybe it's okay in a young woman like that to do a laparoscopy, drain the cyst, clean the cyst out, and then perhaps, I don't know, maybe it's worth doing a study with the dionagist after the cyst has been drained, where the dionagist might actually help shrink the cyst to a size where there's no further surgery required. Or if you're then going to peel out the cyst, it is much less likely to cause long damage.
Look, I was recently to the European meeting of laparoscopy, endoscopy, and there was a nice group in Belgium who showed the data with laser treatment. Laser is very, you don't remove ovarian reserve. It's very helpful. Now, in Italy, we have a proposal with plasma jet, which can be very safe, no electricity, so you don't scratch you don't remove the ovary. Depending also, I agree with you, if the technology will improve, you are absolutely right. You have a very good surgeon, very limited to the removing the cyst, and then you treat for avoid the recurrence. No question, in particular for 10 centimeters.
Okay. Sir, but there is a confusion in always mind, and many questions regarding this confusion. That is the Dynogist versus GnRH analog for the suppressive therapy, as like a suppressive therapy in case of endometriosis. So what is your opinion?
For me?
Professor Felice. Yeah.
Yeah, but you know, we know GnRH agonists from 25 years. And we know that after 6 months or 1 year, it's difficult to convince the women. It's very expensive. It's difficult to convince women to have a side effect. You have to give another hormonal treatment. No, add back. Why don't you start from the progestin? There are many progestin now. We hope to have many more in the future. Then if the progestin don't work, of course, which we use analog sometimes to start, and then we switch to analog. Sometimes it's not easy to treat those patients. Remember that we have not many studies, but many of these patients change gynecologists every 2 years.
But at the same time, there is also a debate, Dynogist versus OCP. So we don't know when the debate will be aimed. Another thing.
It is a patient dependent. It's not we will never give a word recommendation for one drug in this disease. This is a multifactorial, as Professor Khan says, multi-etiological. Now, we have and personalized medicine is the best for endometriosis.
It's really excellent, sir. And the last question to you. You showed us a photo for your team members, and there is also presence of a psychiatric support and psychiatrician. So perfectly, you just put light of the importance of a psychiatrician in the team of the management of endometriosis.
Yeah, because sometimes we have to, they come to our office in a center of, like say, depending where you work, because we are a center of excellence. So patients come to us after too many counseling, very doctors, many hospitals, many surgeries. So you have a special patients, and you have sometimes to convince that what is the disease, what is educational. The counseling is very complicated. As Professor Luke said before, you have to spend 1 hour, sometimes 2 hours, not 10 minutes to discuss with some patient. If it's 15 years old or 20 years old with a cyst, it's dysmenorrhea, it's much simpler. But generally in the reference centers, you have a very complicated, and in particular, if they want a baby and they have a miscarriage, abortion, infertility, they are very complicated. So they have a stress of infertility, stress of inefficacy of drugs, stress of different opinions. Do the surgery.
So counseling is one of the important parts for dealing with this patient. Yes, sir. What is your take-home message for the young doctors or the young specialists who are dealing with this sort of cases? Because sometimes the young doctors are very enthusiastic to do the laparoscopic surgery when there is a presence of a chocolate cyst. So what should be your take-home message towards them?
No, we all agree that the young doctors, but also the old doctors, it should be much more, if you believe me, because also at our age, we try to be very fast and convincing, but we should really penetrate what I am mentioning is to be doctors. That's why, how is your gastrointestinal symptomatology? How is your, have you any other disease? Do you use other drugs? So we have to ask, what is your psychological situation? What is now, for example, there is a lot of interest on diet, no? What we eat, what the women eat. And there are many publications on what is the best diet for endometriosis. This is another small area which is growing, and we have to explore, and we don't know yet. That's why we organize meetings like WES, Seud, ACE, ACE. There are so many meetings like you are doing now today. It's very fruitful because this world is very developmental, very fast. That's why really some of the review papers should be written and rewritten in a few years and updated. It's really very important in this field.
Thank you, Professor Feliz.
Now
the last
thank
question.
All of you. And I have to leave because I have another meeting.
Professor Samina, Madam, yes, do you want to add anything? Professor Samina, Madam, our president of our society, and Professor Saleh Begum Chaudhry, the Secretary General of our society. Do you want to say anything, ma'am? Professor Samina, Madam, first, yeah.
Okay. Thank you, Dr. Sharmin, for your excellent moderation. And first of all, I want to say that Professor Luck and Professor Feliz. On behalf of Endometriosis and Adenomyosis Society, I am Professor Samina Chaudhry, President of Endometriosis Adenomyosis Society of Bangladesh. Welcome both of you together in this conference. And it's our dream that you are with us in this conference under the same umbrella. It's a fantastic session. You made it for us. With you, our chairpersons, Professor Khalid Khan and also Professor Farhana Dewan, and also enriched by question and answer session. And really, it's an outstanding conference session. And your presence and your guidance and said that how much to do for a patient, how far to, what is our limitation and how much to do for them.
Thank you.
And I want to say one thing, that demand already created among the Endometriosis Society of Bangladesh, that we want to have some research work and training program in collaboration with our society members. And if you can guide us, we will be very happy. And is it possible to include Endometriosis Adenomyosis Society of Bangladesh to be a part of World Endometriosis Society? This is a demand from our society members, and especially I am telling it to our president of World Endometriosis Society. And really, I think that this is a very powerful and power-packed session. Thank you very much.
Thank you, madam. Thank you, madam. Salia, madam, do you want to put anything, 1 or 2 lines? Salia, madam, Secretary General.
Thank you, Dr. Sharmin. Thank you very much, Professor Luke Rombas, for your wonderful presentation and wonderful contribution in this session that enlightened us as well as helps us to decide when to do surgery and when do not, and also enlightened us that a good surgeon always think about benefit of surgery for the patient, for a particular patient in planning the surgery. And we always want to want collaboration and cooperative work with the international association and organization, World Health, also as well as all societies, endometriosis, International Endometriosis Society, Endometriosis and Adenomyosis Society. And as well, I also thank Professor Felix Petragalia for his excellent presentation and focus to consider reality as well as outcome in selecting treatment modalities in the treatment of endometriosis.
Thank you, madam. Thank you very much. And it's a great opportunity to get the 2 presidents in the same platform. Thanks and respect from us. Thanks, Professor Luke, for your kind joining. Now over to Lieutenant Colonel Sharmin Hossain for the formal vote of thanks. Dr. Sharmin.
Thank you very much. It's my pleasure to thank the honorable chairpersons. My thanks to the speakers for their excellent deliberation, which has enriched our knowledge enormously. Thanks to moderator also. Thank you all.
Thank you. Now this is the end of the session. We will now join to the Hall B. There is a very exciting session, that is the best abstract competition session. So thanks to all for the patience hearing and to make the session very successful. Thank you. Khalid sir, thank you. Thank you very much.
Thank you, Khalid.